friends, first of all, I'd like to thank Voice of Healthcare for inviting me to this National Digital Forum for Tuberculosis Awareness on the World TB Day. Today, I'll talk about building a resilient healthcare system in India. So, as you are aware, the government of India has committed to end tuberculosis by 2025, 5 years ahead of Sustainable Development Goal 3, Target 3.3. The national target is to reduce the morbidity and mortality rate to the minimum possible level so that it's not a public health challenge in the country. And we, as you know, in the National Health Authority are devoted and committed to this endeavor of the Government of India. At the National Health Authority, we are administering two flagship schemes for Ayushman Bharat, the ABPMJY, Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, and the ABDM, the Ayushman Bharat Digital Mission. Now, both these schemes are playing an instrumental role in helping India achieve universal health coverage by collaborating with various departments and ministries to eliminate diseases and build digital highways to connect all stakeholders in the healthcare ecosystem. Tuberculosis is one of these diseases that we are committed to eradicating from the face of this nation. Let me talk more about how we are leveraging these two schemes to achieve this. The ABPMJY provides an annual health cover of rupees 5 lakh per family for nearly 11.8 crore Indian families for the economically weaker section as per the socio-economic caste census. PMJY is making quality healthcare affordable and increasing access. Over 3 crore hospitalizations authorized in a little over 3 years across the country have taken place. Working closely with the National Tuberculosis Elimination Program, NTEP, we are collaborating with them to leverage the PMJY platform to strengthen and move towards TB elimination. Since a lot of treatment for TB is done on OPD basis, the new package master for National Tuberculosis Elimination Program will be inclusive of diagnostic packages and OPD procedures. While the specifics are being finalized soon, the beneficiaries will be able to avail over 50 diagnostic procedures and 30 IPD and OPD procedures relating to tuberculosis. The Honorable Prime Minister launched the 𝐓𝐿 on August 2 of last year. 𝐓𝐿 is a purpose and person-specific prepaid voucher. At the National Health Authority, we are excited to see the implementation of 𝐓𝐿 under PMJY as we envisage a simpler and more efficient tool for the payment of diagnostic and medicines that will benefit our brothers and sisters suffering from tuberculosis. We are keen to establish a continuum of care mechanism to link primary care provided through AB health and wellness centers and secondary and tertiary care of PMJY. Through these linkages, we will be able to take forward and backward referrals to ensure timely treatment, referrals, and follow-up. This is especially pertinent to ensure early availing of treatment and mapping the disease burden across the country. Coming to our second flagship scheme, we believe that the future of healthcare in India is digital. And this is where the Ayushman Bharat Digital Mission comes into the picture. Now, obviously, Digital India program of our Honorable Prime Minister has successfully created a number of digital public goods and the layers of JAM. So we have the digital identity 1.3 billion and 67 billion authentications have taken place in the last 7-8 years. We have over 420 million Jan Dhan account which provides the financial inclusion to our people. And we have close to 1.2 billion wireless connections which provides communication facilities to our people at a very cheap rate with 4G connectivity. So this ABDM will leverage all this digital infrastructure and play an important role in monitoring and evaluation of the spread and elimination of TB through its digital infrastructure that will provide transparency and accessibility of services and information for all. As part of our technology platform under PMJY and ABDM, we are also integrating with the 𝐏𝐿 platform for more efficient beneficiary identification. Coupled with the Ayushman Bharat Health Account number, our healthcare workers supporting the TB patients on the ground level would be able to get a better view of the administration of the TB treatment. we must tell you that the whole system is going to be patient-centric rather than being a program-centric intervention. The layer of anonymized and aggregated data would also provide researchers and program managers a granular view of the spread of the disease and the effects of various drugs on different TB patients for an effective control and elimination of tuberculosis. Over the last few years, India has made significant gains in strengthening the support structures, program architecture, and the implementation policies for TB control and elimination. This includes various measures such as mandatory notification of all TB cases, programmatic management of drug resistant TB, PMDT, service expansion, national drug resistance surveillance and revision of partnership guidelines. I am confident that all of our integrated efforts and collaboration on the elimination of this disease would help us achieve the government's target of TB-free India by 2025. I wish all of you and this event a success in 2022 and the future. Thank you very much for inviting me to this event once again. Thank you. Bye-bye. Okay.
24th March is celebrated as the World TB Day. And this year, the motto of the World TB Day is that we have to invest in TB and we have to see that how it is removed from our state, our country. Now, the question is that if we talk about TB, I personally feel that in the last 2.5 years, the state has fought valiantly with the challenge of COVID, 3 waves, and again prepared for whatever comes next. And there have been a lot of learnings in public health by the state government. And I'm sure that many of these learnings are going to be utilized in fighting off the challenge of TB also. And that is why, as far as Haryana is concerned, we are geared up to remove the TB from the state by 2025. If I say that in what way we are going to proceed ahead, you see, first and foremost part of any disease is the surveillance part of it. You see, I'm not going into what are the components of the national TB program and what different things are there. So, since those are the things which are available to all the state governments, those are the things which are being regularly reviewed by the central government also, and those are the things which are getting strengthened. But I'll try and focus on the strategy which we in Haryana are going to have already started putting into implementation. And when I say that first and foremost is the surveillance of the disease, it is very important that there should be a very, very robust surveillance of the disease to kind of see the people who are having this infection or who are suffering from this particular disease. Now, this can be done in multiple ways. In multiple ways means that we have tried to link and give access of this program to all different sections of society. We have added civil society, we have added NGOs, we have added private hospitals, we have added schools, we have added colleges, we have added all kinds of health workers. So all these people, they have been added for the part of the surveillance. We have added the Panchayati Raj institutions, we have added all kinds of groups which are available for the surveillance part of it. Now in surveillance, we try and see that how we see that wherever we find that people who are suffering from it, so immediately they are kind of tested for the sputum part of it. So if on sputum, the people positive, they test positive, and then of course the treatment immediately starts, and there might be people who don't test positive, but you find them that they ultimately turn out to be asymptomatic also. So when you find that there are people who have tested positive and the treatment starts, the next part of it is that you have to see that whether the kind of disease they're suffering from is it drug resistant or it is not drug resistant. And then you go to the part of the contact tracing, that which are the contacts which are there. The immediate contacts are there, the primary contacts, the secondary contacts, all those things are there. And then the contacts are also tested, and those contacts who don't test positive, but they might be having a latent disease. So then the treatment line starts for the people who are tested positive, who have the disease, and those people who have the infection, but they don't have the disease. And then the entire treatment part starts. Now, for this entire system, there has to be a very well coordinated effort by different sections of the society, first of all, because as we know that just as in the initial stages, corona had tremendous amount of stigma attached to it. You see, stigma in TB has been there for a very, very long time. In fact, it has been much longer than what the recent such diseases had. So we have to see that patients who are suffering from this, they should not feel that they are being stigmatized. So it is very important that we kind of see to it that there is adequate awareness about all sections of society, and especially the employers, because the stigmatization of a person immediately impinges upon the job prospects which a person is having. So what kind of motivation the people will have to keep these people who are under treatment, knowing fully well that if they are under treatment, it is not going to be any problematic. That is very, very important. So there are a lot of awareness campaigns which have been generated through all kinds of use of media, whether it is a social media or it is a radio, TV, print media, or a large number of meetings with the groups which I mentioned right in the beginning at the time of the surveillance part of it, that how you create awareness about the disease among all these people, and how you also create awareness among all these sections of society that this is a disease which is totally treatable. There are all kinds of drugs which are available. The only thing is that we have to instill a kind of confidence in the patients. We have to instill a kind of confidence in the caregivers. We have to instill a sense of confidence in the employers. We have to instill a sense of confidence in the people who are in the near vicinity of the patients, that once a person is on treatment, then there is no problem as far as all others are concerned. And tremendous infrastructure and tremendous medical education has already gone into it. So as I said, this is the first part of it. Then we, as I said, we have the testing part of it. I talked about that we have to go in for the testing of such patients. We have to go in for the testing for the drug resistance of this patient. So all this requires a full infrastructure. So we have in Haryana the sputum centers, which are in fact available for testing of sputum centers, almost 250 of them, right down to the PHC level also. So wherever the public health, facilities are available, the PHC facilities are available, we are immediately able to provide the sputum testing. And apart from that, once the testing is done, as far as the drug resistance labs are concerned, we already have the drug resistance labs which are now being penetrated into the lowest rungs of the medical facilities by importing and by purchasing more and more CBNet machines and the TrueNet machines. So these are the kind of tests which would be useful for seeing the drug resistivity of a particular patient. Now we already have, it's a kind of facilities which flow right from down. At the PHC level, we have the facility. At the CHC hospital, sub-divisional hospital, at all those places we have the facilities which are there. And then even at the health and wellness centers, which are primarily at the level of the sub-centers or the villages, those are the places where the entire surveillance part that takes place, the meeting of the different people, the meeting of the health workers, the meetings of ASHA workers, ANMs. So they are the ones who kind of become the first kind of point of contact for the surveillance part of it. And then the TB health workers, they take over, they will do the testing part of it. And then the testing, after the testing, the treatment is set by the doctors. And once the doctors have set up the treatment, then it is extremely important. You see, the difference between TB and many other diseases, that here you need a consistent 6-month treatment, which has to be given to a patient. Now the question is, now that is something which has to be ensured at all times. Because if we don't have a regular treatment for 6 months, then the entire effort goes waste. That is why, despite the numbers of TB patients being much less than what the corona patients have been in the last 2 years, still the challenge of fighting corona has proved to be, in retrospect, much easier than the challenge of fighting TB, because here the commitment which is required by the caregivers, by the health workers, by the people who are involved in the treatment part of it, that is extremely important. The availability of drugs is not a problem. The availability of testing infrastructure is not a problem. The availability of all kinds of facilities is not a problem. In fact, in the TB treatments also, right in the initial days, when the patient is coming to the hospital, at that time, whether the patient or the attendant is there, the program also provides for the traveling allowance to be given to them so that they don't have a problem traveling to those places. But I say that one of the most important things for a TB program is that we ensure that the treatment is done in a proper way, and for which what we call the DOT persons, who are the ones who are ensuring that the tablets or the treatment is given regularly every day, and they maintain a chart of it. It can be ASHA worker, it can be a A&M worker, it can be a TB health worker, it can be a caregiver, it can be anybody who's there, it can be a school teacher, it can be somebody else. So all these people, they are the ones who play a very important part to see that the patient that receives the treatment regularly, that is very important. So that is one part of it, where, as I said, that we are trying to do the entire thing in a very scientific and systematic manner in our state. We have already started the mapping of the entire state with respect to the areas where the prevalence of TB is there. And then, of course, at present also, we are going ahead with the all the parameters which I have talked about. But once we have kind of prepared the map of it, it becomes extremely easy for us. Because otherwise, generally speaking, the efforts have been to concentrate on the industrial workers, to concentrate on areas where you don't have sufficient good living conditions, with maybe the slums or a very heavily populated areas where people are not getting the kind of proper environment for staying. So those are the areas which, in any case, the health department has been working for a very long time, and they have been trying to see that the people are isolated and they're given treatment, and then they become part of the regular mainstream. But the main thing is that there might be a large number of people, as we found in some other diseases also, that whom we say who are carrying the infection, but those who are still not having the disease. Now, these are the people who are the carriers of infection. They are the ones who might also be spreading the disease. So it's very important to see that the people with the latent TB infection, they are also isolated. So we have to go beyond the traditional areas where the departments have been going, and we have to see that we identify those areas also and bring them into the treatment. You see, right from the beginning, surveillance, contact tracing, testing, treatment, all these things we have to do in every program which we run from the state government side, especially the TB program. And then we have also made it mandatory in the state that this has been declared a scheduled H1 notification has already been issued, and under it, all the chemists, all the private doctors, all of them, they have to immediately notify that a particular person is carrying this infection. And once they notify it, then of course the entire follow-up of that particular person starts by our district TB officers and the entire system, which is much below them also. So we are ensuring that all the private hospitals also, right from the time of the sputum examination, they should be immediately bring the patient into the system so that the entire testing and treatment part that can start. Then we are also finding that in the fighting of the corona also, there was a lot of problem as far as the surveillance of people who are roaming around with asymptomatic cases was concerned. And in each and every medical facilities, we created flu clinics. So now we have created the sputum clinics in most of the medical facilities. So whoever are the patients who are coming there, we try and see that if there are any kind of symptoms or if there is any kind of apprehension, immediately the sputum examinations are also done. Then although we are giving those kinds of traveling facilities to people, but there is an effort to see that we introduce the mobile vans which go right into the area where the people are not coming. So they do both kinds of things. They will do a tremendous amount of the awareness generation program. They will do the IEC activities, and then they are the ones who will also do the testing on the spot. So the mobile vans are proving to be very, very successful. And I'm very happy to say that some of the corporate sector people have also aligned with us in this. We have a block which has been taken over by one of the Becton Dickinson, which is one of the pharma manufacturing companies. Similarly, the Medanta Hospital is also contributing to the effort of the state government in one of the blocks in Gurgaon. And similarly, some of the Rotary programs and other programs, they are also helping the state government TB programs in a big way. Apart from a large number of the NGOs and other non-government workers who are working right up to the village level, district level, block level, all levels they're working. I will not go into the describing the statistics of how many TB officers we have, what kind of infrastructure we have. Suffice it to say that we have a very, very robust and a strong infrastructure which is available. We have taken up the entire mapping. We are improving the infrastructure for testing. We are taking the all the infrastructure right up to the door level of the patient, and we are creating tremendous amount of awareness among the people, not to stigmatize it, and we give a very regular access to the TB patients for the treatment part of it and the entire part of it, so that there is a total elimination of TB. After all, this is also an ongoing program. Once it is eliminated, you will keep getting it. It's a dynamic thing. There might be people who are again getting it, but then this is something, first of all, it has to be kind of eradicated in one way. And then, of course, the follow-up will keep taking place at the state level. And I'm very sure that with the tremendous efforts of Health Department Haryana, which has done very good work as far as fighting the challenge of corona and running many other public health campaigns is concerned, we'll be very successful with the tremendous support of our health minister, tremendous support of our honorable chief minister, and the dedicated efforts of all the health workers, right from the ASHA workers, the NM, going right up to our paramedical staff, our medical people, and all the groups who are attached with them, from the civil society, from the NGOs, from the corporate side, from the schools, from the colleges. All these people, they will all combine together, and we will see to it that TB is eliminated from Haryana by 2025. This is, of course, I personally would want it to be done even earlier than that, but then this is the target which has been set by the Government of India, and we will try to see that we achieve this target much earlier than what has been set by the Government of India. In fact, 2 of our districts, they have recently been selected for the bronze medal, which means that there has been a 20% reduction in the incidence of TB in those districts, which is based on the incidence of disease, which is also kind of calculated on the basis of various parameters, including the sale of drugs with the chemist and other things. So Palwal and Fatehabad have already been there, but we are going to put many more districts for this kind of reduction, massive reduction in TB in the next about 6 to 8 months' time. And I'm sure that with our state TB coordinator, who's doing a tremendous job, we are definitely going to achieve these objectives of World TB Day. Government of India is holding a meeting at the central level also, at the national level also. There will be a lot of guidelines which are given, and there is tremendous support which also comes from the Ministry of Health and Family Welfare, Government of India. And we look forward to the strategies which are going to be unveiled tomorrow, as well as the best practices which are being followed by many other states, and see that in what way Haryana can benefit from them, and in turn also tell them the practices which we have been following in Haryana, and in what way the other states can benefit from it. So with these words, I will like to complete my address, and I'm sure that in the next 2 years, 22, 23, and 24, as I said, we personally don't want to go up to 25. We try and see that we finish it off by 24. We'll make tremendous efforts for that and see to it that we are successful in this. Thank you. Yeah.
Namaskar. Very good morning to all of you, and I am really delighted to share my thoughts on this National Digital Forum on TB Awareness, which has been organized by Voice of Healthcare. And you've been hearing about why do we mark this day as World TB Day, and you have listened the other speakers. I would like to share a few slides on what the government is doing towards elimination of TB and realizing the dream of our Honorable Prime Minister, who gave a clarion call on 13th March 2018 to end TB from India 5 years ahead of SDG targets by 2025. So in a couple of slides, in my presentation, I will like to walk you through what is the TB disease situation in India. And as per the National Strategic Plan, the main strategies or main pillars of the TB elimination effort is detection, treatment, prevention, and build the capacities and system for TB elimination in India. So I'll try to cover my presentation in what progress we have made in each of these 4 strategies, and then try to showcase the way forward, how the program is leveraging on AI solution, and how the program is now looking forward to address the latent TB by preventive interventions, and how we leverage other line ministries to end TB in India, because there are factors beyond health sector which affects TB disease. So this is in a nutshell my whole presentation would be all about. So now I can share my slides. So as I said, we know that India contributes 26% of the global TB burden. And in India, the estimated incidence rate in 2020, we could reduce the incidence, not to the extent which we want, but we are showing progress specifically in last 3-4 years. And we were able to reduce the gap of missing million in 2019 to just 0.3 million. But everybody is aware that then COVID affected all the national programs, and TB more so, because our health infrastructure, TB lab infrastructure was also pressed into the national response to COVID. But you can see that in spite of COVID affecting all the health programs and TB program, we could still manage to find 21 lakh cases out of 26 lakh estimated cases. And you can see that how it is spread. It affects all areas. It affects urban areas, tribal areas, and how the disease is spread among productive age group, and how men contribute 62% of TB patients in India. And the programmatic data suggests that 6% of all these notified cases have drug-resistant TB, which is much more difficult to treat. And HIV again is one of the risk factor, because TB is the most common opportunistic infections in HIV positive patients. So, as I said, that the National Strategic Plan, the main 4 pillars of National Strategic Plans are detection, treatment, prevention, and build components. So, you can see the progress over the years, how we have gone from, in terms of infrastructure. In 2017, we had 15,000 microscopy centers. We have increased them to 21,000 now. Rapid molecular tests is also, every district has one CBNAT machine, and now we have taken the indigenous TrueNAT machine to the block level also. And the culture DST lab also for, assessing the drug susceptibility. So this slide suggests that the how we have progressed towards detection with the latest technology, and also for outreach, screening and diagnosis. We also have added mobile vans also. And you can see, as I said earlier, that after the call given by Honorable Prime Minister, in 2019 we reduced that gap of missing millions, and we could screen. TB testing has been increased by 20% from 2017 to 2019, and drug resistance with the introduction of NAT machines across the country, the drug resistance testing has also increased. And overall screening, molecular testing proportion is 20% of overall screening test done in the country. As far as the progress in treatment services goes, I mean, a lot of changes has the program has introduced a lot of changes. Like earlier, TB patients used to have multiple tablets, which lead to poor compliance and more side effects. Now the program has introduced fixed dose combinations, so the pill burden has been decreased. And earlier, for drug resistant TB, there were multiple regimens. So we have simplified the treatment regimens to 2 or 3 regimens. And also earlier injection like kanamycin, streptomycin were part of the regimes, and which was having a lot of adverse effects like hearing loss. So now we have injection-free treatment regimens, which will again increase the compliance. And after 40 years, when the newer drugs were found, bedaquiline and delamanid, it has been incorporated in the plan, and under the programmatic conditions, these drugs are given to the eligible patients. And you can see the treatment success rate is also steadily increasing to 83%, and finding more DRTB cases, and the success rate with the newer drugs and newer regimens is in DRTB patient, which is much more difficult, is still encouraging. And with newer regimens now, even newer regimens coming in, we look forward that the treatment success of DRTB will further increase. This slide again shows that how we increase the notification. 2019 we were on the right track. The momentum was really great. Central teams, state teams, and district teams were working really hard, and we could reduce that missing million gap. We took a hit in 2020, but again we pick up our momentum, and we could notify 21 lakh cases in 2021. This is something we have to start working towards. A program is also it is the right time that we should start latent TB issue, because until we stop the transmission, we will keep on getting cases, and the program will keep on treating them. But this is, if we want to end TB, this is the right time to start acting on latent TB cases. So program is intensify the contact investigation, and the eligible group, earlier eligible group, which was children below 5 years in contact of pulmonary TB cases, were given chemoprophylaxis, and so are the people with HIV. But now we are trying to increase this. We are trying to add more age groups to this particular activity, that preventive services should be given to all household contacts, irrespective of their age, after ruling out active TB. In line of that, we have also seen that malnutrition is a very, very big factor for breaking down into active TB from latent TB. So program, though it's a small step, but then program has started giving 500 rupees per month to TB patients during the entire duration of their treatment for nutritional support. And so it is an effort from the central level, but state governments are adding on to this, and they are adding supplementary nutrition also. So this is just to it is to complement the efforts which are in the clinical domain of the program. So this is one effort which was started in 2018. And what we have seen that earlier, say in 2015 to 2017, we could see that the private sector engagement was not addressed in the way it should have been addressed. And we are aware that 50% of the patient go in the private sector, and still those notifications were not coming to the program. But with few interventions like fixed dose combination and engaging very actively with the private sector, you can see the notification has tremendously increased in 2019, and in 2021 it is even, in spite of COVID, we could get the patients being treated in the private notified to the program, so public health action can be taken for those patients also. And this we did with our partners, and in cities where private sector notification was expected to be lacking, and by active engagement from the program side, we could get those patients who were being treated in private earlier. And now it is really happy to note that the private sector is very actively engaging with the program. Other thing which I would like to highlight today here is government alone cannot address this issue of eliminating TB from India. We need each and everyone's support. We want to make it a people-centric program, and we want to involve each and every stakeholder which can contribute. So we have institutionalized the engagement of community by making state TB forums, where the influencers, the stakeholders, both the program implementers plus the patients, with TB, and civil society and NGO and other stakeholders come on a platform and discuss the local issues and get the local solutions for it. So the quality of TB services is improved. And we have formed, there is a TB forum in each state. They meet biannually. Then all the districts have their district TB forums, with district magistrate being the chair, and local issues are discussed there. People suffering from TB who have taken the treatment are part of these forums, and because they have seen, they have gone through the disease. So when they bring out the issues to the local level, that is the whole idea of these forums. And also the program has engaged the cured TB patients by making them TB champions who work for the cause of elimination of TB by awareness, by getting the symptomatics to the treatment centers, and by advocating about TB services available, and helping them, counseling them about the adverse effects, where to go. And for this, we have made self-learning courses through digital platforms like 𝐓𝐿, and who have smartphones. For the TB champions who have been identified by the states, who have feature phone, can learn about TB and the services on TB Vani. And then again, who do not have any mobile, they can be brought to TB center, and our TB staff will show them videos about basics of TB, epidemiology of TB, in a very, very simple language, and where are the facilities, what can they, how can they contribute if somebody wants to contribute to the program. And the guidance document, broad guidance document to the states have been issued by center, how to engage the community meaningfully. Of course, the states take their call, and as per their needs and their situations. And these guidance have been given from the center, so that it doesn't. TB patient is not just a beneficiary of services. He or she should be part of the whole process in improving the quality of TB services. And we are taking this component very, very seriously. Our Honorable Prime Minister has said himself that until the, at cure TB patients talk about how to improve the services, it will be very difficult to, get the change which we want. So taking advice from Honorable Prime Minister, we have taken this component very seriously, and now we are trying to engage the communities at the ground level, and at every district, every block, it should become a Jan Andolan, and that's why I'm so happy to share the virtual space with you all, that we are doing this program so that whatever we are doing reaches masses and they become part of this program. So, as I said, that we want to engage each and everyone. So, program has made efforts to corporate sector, and a lot of corporates have come forward, and they are doing a lot of good work in their areas. And we have to have a healthy competition among them. We have divided them into silver, gold, and platinum and diamond categories. And you can see here that a lot of corporates are coming forward and doing very, very good work in their areas. Again, as I said, tuberculosis is something beyond health ministry. The factors affecting tuberculosis, be it malnutrition, overcrowding, overall living standard. So it has to involve other line ministries also. So we have done MOUs with the different line ministries, and we see a lot of positive response from them. So we have engaged with railways, their clinics, and we get notification from their hospitals and clinics. We have engaged with the Defense Ministry, and in all ACHS clinics, send us the notification, and then we do the public health action. Our staff does the public health action for them. Again, we also give laboratory consumables for the army hospitals. And Ministry of Tribal Affairs has come really forward, and with many initiatives and newer. They have also, they are also supporting us through extra fund, which is there available in their ministry for plugging the gap of, say, infrastructure and other supplies. And again, through their efforts, whatever their outreach programs are there, we have incorporated TB component into it. So we have, so to say, a force multiplier, because there's another ministry doing the work in tribal areas. So we just sensitize their staff in TB issues, and we are getting support from them. Again, with the Ministry of Labor and Employment, we have made workplace policy, and it got disseminated. So in a nutshell, we're trying to say that now the program is moving towards engaging each and every department which can help us. Taking it forward, we have requested our Honorable Vice President to address the members of Parliament, because they know their area very, very well. They represent their constituency. So we have sensitized the parliamentarians, honorable parliamentarians, for what can they do and what are the basics of TB, and in their area, what can be their contribution. We made a handbook for them, which is in very, very easy language, and basics are incorporated into it, that if they want to do, what are the areas they can support, how to monitor the progress of TB indicators in their constituencies. And as I said, we have a national strategic plan. So some states have come forward and made their state-specific strategic plans, and they have openly declared that they will end TB way before 2025. And many states like Kerala and Himachal are doing really, really good work in this direction. And these are the states which have committed. They have a written, documented, costed strategic plan in their states, because from the central, TB division, we can give broad guidance, but ultimate implementation has to happen in the states. So they have made their own strategic plans. And this was an effort to have a healthy competition among the districts and states to work towards ending TB. We have plans for incentivizing states and districts. If they get reduction in incidence in their state and district from the baseline of 2015, suppose they get a reduction of 20%, so they are eligible for bronze certification. If it is 40%, silver certification. If it is 60%, then incentives are given for gold certification. And if they make their district or state TB free, then they get president citation, plus they get monetary support as well. So the process is they submit the claims, and the individual teams, independent teams from ICMR, NIE, National Institute of Epidemiology, and WHO India and IAPSM, they independently assess their claims, and on the basis of their assessment, the awards are given. So we see a very, very positive competition and very, very healthy environment where the states and districts are now working. Last year, we had some claims, and out of them, Budgam and Lakshadweep were found to be TB free. So they were given that award. And taking cue from the last year, this time, 201 districts and 10 states have submitted their claims. So the process is going on. A process of assessment is going on, and the results will be. The states will be facilitated on the occasion of World TB Day, that is today. So during the World TB Day celebrations. Now I'll just talk about what the program is thinking towards and working towards, leveraging the available, technologies. So as I said, we have the best rapid molecular testing facilities made available at district and sub-district levels. But then we are aware that all the TB patient, pulmonary TB patients specifically, cannot produce sputum, which is really a challenge to diagnose. And X-ray facilities are not there, say in each PHC or each block. So for that, we are working towards an AI solution for chest X-ray reading and communicating the results to a PHC medical officer and through telemedicine. So we are working towards that. Also, we are working with our partners for a cuff-based screening tool. It is in very advanced stage, and it's as a proof of concept. We will be getting the results very soon, and once it is done, then it will be made available. Now, though the TB program has been decentralized to now currently it is up to the block level. We have a tuberculosis unit at block level, but with the health and wellness center, more than 80,000 health and wellness center has been established, and we have a community health officer there. So we want to further decentralize it to a population of 5,000, and that would be the one-stop center for diagnostics, treatment, preventive, promotive services of TB. So the program is engaging with the community health officers, and will be launching a 21-day campaign, so that each health and wellness center will have a registration on 𝐏𝐋, which is our digital platform where all the data gets faded, and it's seen on dashboard at central level. And the program is planning to engage the health and wellness center as a complete package, where the sample will be given, the results will be available there, and the treatment will be started at health and wellness centers after one consultation with the doctor. So we are trying to further decentralize the TB services to a population of 5,000 health and wellness centers, and we are launching a special drive for that. Again, as I said, it is very, very important to address the latent TB. So what we are proposing, we have increasing the age group above 5 years to contacts of pulmonary TB, and also now a new regimen has been uh, is available, which is very, very promising. And the current chemoprophylaxis which we give is for 6 months, which is very difficult for somebody who does not have a disease to complete that chemoprophylaxis for 6 months. But now the newer regimen with INH and rifampicin, it's 12 weekly doses. So it is very effective. The studies have shown that it is very effective, and the compliance will be better if I have to take it only for 12 weeks. And also we are working with ICMR to get a new skin test. It is also in very, very advanced stages, and which is very easy to administer, very easy to monitor, and to rule out active TB, and to look for latent TB infection. So once we have these tools in our hands, it would be this is the right time so that we develop these tools, and we are able to address the issue of latent TB, so that transmission is cut, and we realize that ultimate dream of ending TB in India. In spite of a lot of efforts made, there still exist many challenges because of the diversity and the vastness of the country, geography of the country. So we still have challenges in accessing the diagnostics and drugs in some areas, specifically hilly and tribal areas. But by using molecular testing and telemedicines and all the AI solutions, and basically decentralizing it to the health and wellness center, we are looking forward to address this issue of access to diagnostics and drugs. Recently, we have concluded the National TB Prevalence Survey, and one thing which has come out in this survey was the health-seeking behavior, which was quite low in spite of having cough for 2 weeks. There is still the health-seeking behavior is not very positive, and they try to take the medicines from the local chemist or the local doctor available there, not actually thinking that they might have TB. So that the ground reality is that still people don't know about tuberculosis. And so program like this, what we are doing today, if it is done, that we have to get the basics to the people in very, very simple language, that's a curable disease. And we have to put extra effort in making people aware, make it a felt need of the community, that TB screening and symptoms of TB is very, very important. So that's we have to work toward. Again, TB preventive interventions, as I said, they are not very comprehensive, but then, as I told in the earlier slides, that we are increasing the eligible population other than the children under 5 and PLHIVs. So that would also, and with the newer intervention, like I said, INH and rifampicin regimen, these are some intervention which would address this issue of TB preventive, issue. And all said and done, still we have only 100 years old vaccine, which is BCG, which only protects the children for 1 year, and protects from them to develop a very severe disease. So it's not a very and it is not effective in we cannot give it to adults. So need of the hour is to develop effective vaccine for adult population. So we are working with ICMR, Department of Biotechnology and DSD to mobilize for faster vaccine solution. Ultimately, to end TB, we need an effective vaccine. And other thing, as I said earlier also, that there are determinants which are beyond health, and so they have to be taken care by other departments also. And we are working towards this particular engagement, holistic approach, all of government approach to end TB the way we did, for COVID. that all the line ministries, all the departments should join hands and work towards this aim of ending TB in India. So this is my last slide. Thank you so much for listening to me, and I'm really happy again to the organizers that they have made this National Digital Forum TB awareness program organized, so that we should talk more about TB in all the possible platforms. And I thank you all. And TB हारेगा, देश जीतेगा. Namaskar.
warm welcome to all the dignitaries on this panel, and my compliments to Voice of Healthcare and Khushbu and her team for always being ahead of the curve in bringing us all together on extremely relevant points in healthcare. Before I proceed further to the topic, I would like to introduce my panelists, Dr. J.L. Meena, an old friend from the National Health Authority. Good afternoon, sir, and welcome. He's the Joint Director and Division Head, NHA, Ministry of Health and Family Welfare. Dr. Ravinder Kumar Diwan, Director good afternoon, sir, welcome. Director, National Institute of TB and Respiratory Diseases. Urvashi Prasad, Director, Development Monitoring and Evaluation, NITI Aayog, Government of India. Dr. Suvendu Sahu, Deputy Executive Director, Stop TB Partnership, Geneva, Switzerland. He joins us at a very early hour from Geneva. Thank you for being there. Amanda Fernanda, Program Director, TB 𝐓𝐁'𝐒, South Africa. Welcome, Amanda. And Ridhima Sodhi. Hi, Ridhima. She is with the an international health economist. It's delightful to have economists with us in healthcare. Consultant TB programs, Clinton Health Access Initiative, consultant P4H Network, WHO. So without much ado, and given the kind of panelists we have, I'll just take a minute to set the context. Tuberculosis has been around partnering humanity as far as we see and beginning of civilization. Unfortunately, it still continues to travel with us. When we look at the demographics which get affected by tuberculosis, the unfortunate truth is it affects people in their productive age group, in young adults. And this brings high economic and social costs. And if I recall way back, it was always spoken of in hushed tones. Today, thankfully, at least people are more vociferous about the need to take care of this issue, and therefore do not hide the fact that there is somebody who has tuberculosis. But still, there is a certain measure of hushed tones. Compounded today with COVID-19, the general sense that is there is that the situation is going to get worsen. And people with underlying diseases, autoimmune diseases, chronic respiratory infections, etc., and worst of all, people who can't afford healthcare or have access to healthcare further get marginalized in the story. So it is extremely vital that we not only reaffirm our commitment to ensuring that there is, not only in India, but worldwide eradication of program, but continue pressing the pedal on telling people about this in a much more meaningful manner so that the fear factor or the marginalized factor is removed. In India, and I'll stop here and move straight into the discussion, among all the states that are affected by tuberculosis, our most populous state, Uttar Pradesh, holds about 17% of the entire burden of tuberculosis. Now, having them in pockets like this perhaps would have been not so much of a challenge because they are concentrated, but unfortunately the story just goes on. So with that brief context and the fact that the government has done so much, governments all over the world, and WHO has done so much, why is it that we are still at this point? So the discussion is around telling our viewers a little more about what the current context is, as well as dispelling myths around this disease. I'll first move to Dr. Diwan. Sir, given this piece of COVID and the fact that many media reports, as well as on television, they seem to indicate that there is a relationship between TB and COVID. So is there any overlap in the pathophysiology between the two? And in terms of prognosis, what will be the intersection or the impact of these two? Over to you, sir. You're on mute, sir. If you could unmute yourself, please.
Am I audible now?
Yes, yes, please.
Okay. So before the COVID pandemic hit the world in 2020, tuberculosis was the single infectious agent claiming the maximum number of human lives. And as we know, as per the statistics which is still ongoing, COVID has overtaken. And yet tuberculosis, as all of us know, is a major killer, and especially because it affects poorer populations and younger productive populations. So before the COVID pandemic hit us, in 2017, in the National Strategic Plan, the Government of India resolved that in the Sustainable Development Goals, we had decided to eliminate TB by 2030. That means reduction in the incidence of TB by 80%. And that had to be achieved by 2025 instead. So the speed of progress towards achieving that goal was steadily increasing. Whatever gains we had made in terms of the national program, in terms of the financial outlay, in terms of the commitment of the medical apparatus as well as the political administrative apparatus, we were making a consistent progress. Now, when the epidemic came, most of the healthcare resources went into the care of COVID pandemic. Now, both the diseases are respiratory in nature. They are vastly different because tuberculosis is a chronic disease, while COVID is an acute disease. It's an acute respiratory virus infection which comes and progresses to severe or mild or moderate intensity and passes away. While tuberculosis in its incubation period itself takes 6 weeks, minimum 6 to 8 weeks to get the infection to manifest, and sometimes may take years to manifest. And it's a chronic disease, and the treatment also goes on for minimum 6 months. So these diseases, though being in respiratory nature, so sharing the context of presenting with cough, with fever and expectoration, they are still very different diseases in their pathogenesis. And most of the deaths, as we know, into COVID took place because of the hypersensitivity reaction of the body and various other factors, complex factors which are yet to be elucidated. While with TB, we have a lot of knowledge accumulated over almost centuries about its pathophysiology. And so we were on the headway. So I do remember that in 2021 World TB Day, because the COVID wave was waning away, so we observed the World TB Day with the health minister chairing the meeting, in which we were assessing what the 3 districts in the country had achieved those results which we wanted to achieve by 2025. And one particular state like Union Territory had also achieved the results. And there were various districts in the country which were in the stage which were graded as gold, silver, or bronze. That means they were on the way to achieve the target of 80% reduction in the incidence by 2025. But all those targets got a severe setback, as we know that mortality for TB, which has been steadily decreasing since 1995, got first time increased in 21 and in 22 also. So all those programs have got a setback. We have somewhat silver linings because the health, respiratory etiquette and hygiene, which has been promoted by COVID pandemic, will go a long way if we adopt it at a large population level in preventing spread of TB. Number one. Number two, the way we have developed technology so fast to deal with COVID and use of CBNet machines and various technologies which can come in the way and development of vaccines. Those techniques can also be and also the use of telemedicine and artificial intelligence to interpret X-rays, etc. They can be very meaningfully used in controlling the epidemic of TB also. And we can also use the newer technologies, the opportunities which have been opened in terms of diagnostics of TB, therapeutics of TB, as well as taking care of individual patient at the level of a program, nation, and society. So these are my initial thoughts. Thank you.
Thank you so much, Dr. Dhiman. I think you put it wonderfully to say that they're totally different entities. And as you very rightly pointed out, the diagnostics, I remember when COVID started and we were looking around for the diagnostic labs across the country, it was this network of labs which was pressed into for identification of COVID. So there, like everything in health, there are synergies, but they're very distinct identities, and they should not be mixed up. So with that, I'll move to Dr. Meena. Dr. Meena, sir, the NHA has done a fantastic job and is continuing to do so with the rollout of the digital card, Ayushman Bharat, etc. So, in your opinion, with the National Tuberculosis Eradication Program, as Dr. Devan said, there has been a slight setback because of the accessibility of people to continue enroll into the program, get their medicines, and get tested. Uh, will there be any change? Do you envisage that happening? Over to you, Dr. Meena.
Yeah, good afternoon to everyone. Especially in the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, number of the diseases already incorporates about 1593 packages already incorporated. And the important thing in the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, we have the number of the hospitals impaneled in this Yojana. About 27,000 hospitals is already impaneled. Because previously the very difficult is the private hospitals available in the remote area, which is not available. But in the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, the 50% of the hospital is in the private sectors. So the availability of the hospital is the first priority, so that the patients go to the nearest hospitals to take the treatment. The another important things in this Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, that most of the TB problems in the below puberty lines families, and we already covered all the families according to the STCC data 2011, and we gave about 5 lakhs of package per years to the family members. And we are also incorporate the diagnostic test in this ABPMJ. So we are also empaneled our laboratories for the diagnosis of the TB, because when you prevent the or cure the TBs, this is very important. The identification of the TB patients on the times is very important. So investigations on time is very important, and availability of the hospital is also very important. So both things is in there in the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, the availability of the hospital as well as the availability of the diagnostic test also. And the other important thing is in this the complication. If you have the complication, we are also treat in the higher facilities according to the referral system is also there. And recently we are also discussed with the TB Pro or TB units of the Ministry of Health and Family Welfare. They are also incorporates on the IT platform of the NHA, that how we treat the TB patients according to the NHA platforms. So I think after this Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, most of the complications of the TB and remaining things of the TB is already incorporated in our package. So we are very good for the treating the patients, especially in the poor families. And hospital availability is also there. The continuously improvement of the package is also there, so that the hospital is motivated. And the important thing in this Ayushman Bharat Pradhan Mantri, if the hospital is doing a good job, we are also give the advance payment through the green channels. So the hospital is also motivated. Related to the payments, we are also ensured that the payment of the Ayushman Bharat beneficiaries to the hospitals within the 15 days, if portability then within the 30 days. So we are also ensure the payment to the hospital and also ensure the quality, because in Ayushman Bharat Jan Arogya Yojana, if your hospital is NABH full accredited, give the 15%. If in the metro city, give the 10%. If in the aspirational districts, give the 10%. If the PGQ and PG seats, give the 10%. So according to the qualitative, we are also give the incentive to the hospitals for the better treatment of patients. So all the things is already covered in Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. Or I think the availability of the hospitals and the awareness is very important. So with the help of the Ministry of Health, I think awareness is also very important for the TB to eliminate TB from the Indias.
Absolutely. I think you put it very well. So actually, with the starting of the Ayushman Bharat program, there has already been an immense opening up of the delivery system. And as we all know, about 40% of tuberculosis is latent. So
Yeah.
with this opening up and the 27,000 hospitals coming on board, the early diagnosis and picking up of cases becomes a huge thing. So, in a manner of speech, if I were to say, there has been a huge impetus with the NHA coming in with the Ayushman Bharat program. People will be picked up earlier, diagnosed, as well as that the complications which occur that can also be taken care of, which is a huge game changer, I would say. Thank you so much, Dr. Meena.
Thank
With that, I turn to Amanda. Amanda, globally, tuberculosis services have been affected. Uh, yes, COVID has made it worse, but in your experience and given the positioning that South Africa has, and you've done a great job by flagging things up front, do you see any change or any global experiences which, listening to Dr. Divan and Dr. Meena, that you would like to add to as to how do you alleviate people from the pain and suffering of this disease, given your experience? Back to you, Amanda.
Thank you, Dr. Singh, and thank you to the previous speakers as well. So just to give a perspective with regards to South Africa, we have about an estimate of 167 people that die from TB every day. And I think this is quite heartbreaking because, TB is a curable disease. However, when one asks themselves why, there's no one answer to that question. So TB, like any other disease, cannot be seen in isolation or be made a responsibility of only those that are infected. So a lot of factors really need to be taken into account. So one of the things that we have seen is that there's very limited access to TB prevention education that is being done and that is available. So clients in health facilities benefit from health education on TB prevention because while they are waiting for health consultation, there's health education that's happening in the waiting areas. However, when you look at communities, you don't have an avenue for this. So an example, we don't have media slots, we don't have posters, billboards, and ambassadors that share their story continuously on TB prevention and engagement. However, in the past 2 years, what we have seen is that when you involve community-based education organizations and educating their caregivers, it actually increases the level of TB education. Remember, the community-based organizations are the ones that sit with communities, they live with communities, and what they do is they have dialogues and support groups and actually use community meetings to slot in information about TB. And most importantly, this then links in for us to be able to actually even do TB hotspot mapping, where we could be able to say, looking at our TB case notification, we can be able to determine where exactly is TB the most in our communities. And we actually use these organizations so that they can be able to kind of assist us. TB also remains a very highly stigmatized disease, which has a very devastating social and psychological impact because it really causes barrier to access to testing and also barriers to treatment adherence. So my experience has been that, people affected by TB want to be heard. So what we have done is that we have provided psychological counseling so that stigma can be addressed. And just to share some of the reflections and the discussions that people affected by TB have shared. And one of the things that they have said is that actually what they want is that they would love to be counseled for treatment readiness, because really they say that they want people to take into account pill burden from pre-existing conditions, because most of our clients that have TB would either have HIV or on diabetic medication or on hypertension medication. So now when someone is diagnosed with TB, they really would benefit from having treatment readiness counseling. And also the provision of being able to have a treatment body if they as a client choose so that this treatment body can be a accountability responsible partner that will support them actually throughout the process. And most importantly, one of the reflections that they shared throughout these psychological sessions when they're diagnosed with TB is that they would love a platform to discuss the treatment side effects and how to report them for adverse drug monitoring. And therefore, that could also allow for a proper referral pathway when they decide of where to access health services. So what we do know is that clients do interrupt their treatment for various reasons. And in the same sessions that we had with them, one of the shared factors that they said, and the reasons for this is that beliefs come into the context, grief and trauma, gender-based violence, unemployment, and sometimes also fear of losing a job, where someone would say as soon as they get better, or they return to work, or at most times, even if they are not better, they would not be able to come and start their treatment because missing a day's work would actually impact on them having an income. Substance abuse, and also just lack of support and family difficulties. So I think one of the things that we really need to do that could definitely help us to eradicate TB globally is that we actually need to include psychosocial support, because we have seen that it actually assists with treatment adherence, and ultimately it improves the TB treatment success rate, because we have the treatment readiness counseling, we have the treatment adherence counseling, we also have family counseling involved. And what I've seen is that people affected by TB, they want to talk, they want to be heard on how to identify how their identity and their beliefs and their culture and their environment actually affects them in relation to the illness. You know, the call to invest in TB this year also needs to include care for the caregivers. You know, one thing I've seen is that healthcare workers know their clients, they know the communities they serve, and they need to be involved in all discussions actually for them to be able to be included in how do we end TB by 2030. So what I've seen is that when you sit with healthcare workers, an example, at the end of the month, and you're trying to verify their data on the TB program, they know exactly what is going on in their facilities. And when you interrogate their data, they actually will tell you that actually, if we could put in these changes, I know that, you know, it could improve the TB outcomes of my facility. They actually get excited when the changes get implemented and they see a small change that can actually significantly improve their performance and actually save lives. So I think those are just some of the few lessons that we have learned this side, to say that we actually just need to look into the whole psychosocial well-being of a client for us to be able to know that we can be able to eradicate TB. And most importantly, to also know that it is not everyone that has access to TB services. Those that benefit are those that are actually coming to the health facility, but we also need to really target communities so that we can be able to find a way of how do we find TB, test clients, put them on treatment, and ultimately eradicate TB. Thank you.
Thank you, Amanda, for those brilliant insights. And I think what you very rightly mentioned, the stigmatization and the involving communities in the psychosocial counseling is extremely important. I think based upon that, from CII, the Confederation of Indian Industries, we've started this movement along with the Ministry of Health and Family Welfare of taking a TB eradication pledge for all our companies, trying to work alongside with them. But that is, as you very rightly pointed out, kind of brings them that kind of confidence, as well as I think you mentioned very rightly that you have to close the loop on the feedback as far as the caregivers are concerned in society. So, which gives me a great segue, Dr. Saul. Stop TB partnership, right? And what Amanda just left saying, that when you deal with communities and you try and do psychosocial counseling, partnerships are very, very important. What would you say, based on your experience, is the way forward?
Thank you, Dr. Singh. Greetings from the Stop TB Partnership from Geneva. Let me at the outset remind us that 24th March coming up is World TB Day. And this time the theme for the World TB Day is Invest in TB and Save Lives. So let me talk about the Stop TB Partnership. This is a global partnership to end TB. And this is based in the United Nations system in Geneva. We bring together diverse stakeholders, right from government of high TB burden countries to donor country governments to civil society to academia, research, businesses. All of them are there together in this global partnership. Over 2,000 members. We have a board which is also quite diverse. The current chair of the board happens to be the Health Minister of India. So we are very inspired by the political commitment of India to end TB ahead of the global target. Now, let me talk about just briefly about TB. I think, Dr. Singh, you very rightly said this is a bug that has partnered with humanity right from the beginning. We must not think TB as any other disease. Today, 2 billion, not million, 2 billion out of 8 billion people in the world are infected with the bug. And all of them carry a lifetime risk of developing active TB disease. Each year, we know that 10 million people develop TB and 1.5 million of them die of it. This is a disease which is preventable. It can be treated to cure even. But yet 1.5 million people are dying because of this disease. And just imagine, 10 million people get TB each year, 1.5 million die. 15%, 15%, no match to COVID in terms of the percentage dying. This is the status of TB currently. And let me also remind everyone that 1 in 4 TB actually comes from India. So any progress that happens in India is actually progress made globally. So very important that we see progress in India, and we are seeing good progress there. Now, let me talk a little bit about what we have been doing from the Stop TB Partnership. We do several things. We do a lot of advocacy work. We do advocacy at global level, also advocacy with some strategically important countries. I recall our Stop TB Partnership board meeting in 2018 of March 2018, where Prime Minister Modi spoke in a pre-board event. And that, in my view, was was a turning point for the TB response in India, and we saw how the budgets improved and things happened in India. We work with many such high TB burden countries, but at the global level, let me remind us that there was a UN high-level meeting where all countries with the heads of states and their delegations agreed to a political declaration. This was in 2018. A lot of work was done by Stop TB Partnership. In fact, the first call for holding this UN high-level meeting came from our board, and we followed it up with WHO and the UN system. In 2023, there will be another one, the second UN high-level meeting, which is another opportunity. We are working for it. We also work at the global level for advocacy with political groups. For example, this month, at the end of March, 29th and 30th, under the presidency of Indonesia, the G20 are meeting, the health working group. There are 2 days of meeting just on TB. We are very glad that Indonesia has championed the cause of TB. And let me remind you that the next presidency of G20 is India. So we are expecting that India will carry forward the legacy that will be set by Indonesia. And just to remind that G20 has half of the global TB burden amongst the G20 countries, and they have the capacity. Their economies are huge, and they can end TB very easily if there is determination and political commitment. Now, some of the other things that we do is we do a multi-year global plan, which is a costed plan for all that is needed globally to end TB, to move towards ending TB. Currently, we are developing the global plan for the period 2023 to 2030. So that's the last part of the multi-year, series of plans that we have developed. This is under development, will be published in the mid 2022. I'll talk a little bit at the end of what I'm saying now about what it shows for us. But before that, let me also tell about some other things that we do. We know that TB response has been a very traditional response. So first of all, it is very biomedical response. And if you understand it, TB is not just a biomedical issue, it is a social issue as well. We heard about from Amanda about stigma, and so we do a lot of work to expand the response to TB beyond the biomedical diagnosis and treatment. We also do a lot of work for innovation, because TB has been in the past working with very old tools, old approaches. I'll give you one example. Today, you can screen people with the X-ray, which is as small as a laptop in your hand. It can be carried anywhere, and the reading of that is done by artificial intelligence. And our teams in 𝐕𝐈𝐑𝐓𝐇 initiative of Stop TB Partnership have demonstrated that artificial intelligence and machine learning today are better than trained radiologists. And this has changed the things, imagine in countries in Africa, you don't have radiologists to read the X-ray report. Things can now happen at scale, and many things can be done which appeared like not feasible in many parts of the world. So a lot of innovations are happening in digital health, in diagnostics, in approaches of screening, multi-disease screening. I think India did a great piece of work on bidirectional testing for TB and COVID. And we learned from India, and we are working further on it. And this month at the end, 𝐕𝐈𝐑𝐓𝐇 actually will issue a call for multi-disease screening and testing. 𝐕𝐈𝐑𝐓𝐇 is our innovation platform. It provides grants to people who want to innovate and want to have different approaches to TB care and prevention. We also have a global drug facility in Stop TB Partnership, which is a platform for countries to procure quality assured TB medicines at the same cost. So India, with all the market there, huge numbers of people, and a small Pacific island get the drugs at the same price. So, and we also do some intervention, which are market intervention to reduce prices and make TB drugs more accessible, particularly the new ones that have come and more in the pipeline. We also have a team that works with countries to support them with technical assistance, and also support communities for community-led actions and provide them the tools for gender, stigma, rights, and a lot of progress has happened in the recent years related to these softer issues in TB, but which are also important. And then let me come to the last part of what I wanted to say here. In the global plan that we are developing for 2023 to 2030, we did some modeling and costing. And let me tell you that the COVID pandemic, when it started in 2020, we also did a modeling and alerted the world way back in May 2020. We did a publication in a peer-reviewed journal with the best modelers in the world, which showed that the impact of COVID can be huge. And now we have repeated the modeling for the global plan. And what we see is, despite the impact of COVID, which has for the first time increased the number of deaths and reversed the trend of declining deaths due to TB, despite that setback, it is possible to end TB globally as envisaged in the Sustainable Development Goal 3 by 2030. But business as usual is not an option. What needs to be done is increased investments in early diagnosis, not just diagnosis, early diagnosis of all TB, all forms of TB, effective treatment, and prevention. And prevention including a new vaccine, which there are several in the pipeline, and we will need to see how the vaccine research is fast-tracked, and we have a vaccine by 2025, so that the last part of that 2025 to 30, there will be impact, and we can end TB by 2030. So all this will require increased resources from the global perspective. If you look at the global level, the currently available funding for TB care and prevention, as well as research and development, needs to be quadrupled 4 times. But we believe that it is possible. And if we don't do that, it will be more expensive. So that is why this year, the World TB Day theme, which actually is led by Stop TB Partnership, we do a consultation, and every year we set a theme. That is why the theme this year is Invest on TB and Save Lives. So I will end there. Thank you.
Thank you so much, Dr. Sahu, for putting that perspective and demonstrating the power of working together. Your last comment was very interesting, that we will be able to stick to our goal by 2030. And that would require, as you rightly pointed out, picking them early and ensuring that they get the required treatment. While you're doing such stellar work, I think at one point as a clinician, as well as in my role with CII, what at the back of our mind, because we follow a number of camps that are held across the country, sputum examination, because in a setting of where we are constrained for diagnostics, though Dr. Meena at NHA and Dr. Kumar Devan, they have been doing a lot of work in making this movement happen at the last mile connectivity. But if we could come up with a solution where sputum examination is not required for diagnosis, right? Then we will definitely be able to make sure that the spread does not happen. At the end of the day, dispensing with a simple thing like a cup in which they spit out, right? That holds. That's the basics of tubercle bacilli, right? They stay in the environment and are hardened to be able to succeed for years on end. So is there some way in which we can sort of eliminate that level of investigation, like you mentioned, the X-ray with the computer, laptop? Perhaps some amount of work, if it could be done, would be a thought I'd like to share and leave with you in the partnership. With that, I'll move to Urvashi. Urvashi, are you there?
Yes, I'm here.
Yeah. So, Urvashi, you are in charge of evaluating as far with NITI Aayog. In the evaluation perspective, right? And the fact that tuberculosis in the evaluation perspective, and that tuberculosis forms a very critical catalytic point in multi-drug resistant story. From NITI Aayog, would you like to share some of the challenges or the methodology as far as the monitoring and the evaluation of all the endeavors so far?
Yeah, thank you for the question. I'll actually, I mean, although I'm working now in monitoring and evaluation, my background is in public health, and I've been working in public health for several years, and also in the TB space. So I think I tend to use that lens more broadly, and of course, monitoring and evaluation within that. But I look at the whole space much more broadly. So I think a few issues that I think the other panelists have also highlighted, which I'd just like to endorse because they are equally challenges for us. from the policy point of view, when we're looking at it here in Niti Aayog. I think, one is that there is much that we still need to do at the prevention and the primary care level. I think this is a challenge with TB, and this is a challenge with many other health issues as well. That we've historically had a very cure-focused health system, and we haven't focused adequately on the prevention and the health promotion and also the early detection part. And I think each of these is very critical in the context of TB as well. So when we talk of health promotion or prevention, I think nutrition is something. And even when I've worked with TB patients in urban slums across India, many of them would say that yes, you've given us this heavy medication, but we actually don't even have food to eat. It makes us very sick. It makes us very unwell. And then you see sort of the adherence to that medication dropping off. And so actually much of the work that we had to then do was to somehow try to ensure adherence to the medication. So I think that holistic approach, of which nutrition is a very important part, overall well-being, also the mental health, of TB patients. We found so many TB patients who, had depression, who had anxiety, who had other issues. And I think some of this is not talked about enough. But these are very, very critical issues because, ultimately in somebody sticking to their treatment, getting well, these play a very, very big part. So I think that overall sort of focus shifting a little bit just from the cure side to also the public health prevention and also early detection. Like with most other illnesses, even in the case of TB, we are all well aware that the earlier we can detect it and diagnose it, we have a much better chance of not only treating that individual but also preventing further spread in the community. So I think we also need some community-based, cost-effective approaches in that. So, of course, we have the diagnostics, but even a step before that, even for screening, even to just identify people who might potentially be at risk or who might potentially be showing some symptoms, I think that is also a step that, we need to really focus heavily on. So I think from the policy side, that is something that we are really looking at the moment. Then, of course, we've already spoken of diagnostics, we've spoken of treatment, but as I said, for treatment, we also need to think about it much more holistically. It's not just the medication, but, all the other support that the patient needs. That is also very, very important. And then I think, the social stigma point was very rightly pointed out, because this is something that I've seen and it becomes even worse with women. In many of these communities, women have to leave their homes, children have to drop out of school. So there's really far-reaching impact, that this illness can have and does have. And we need to really focus on all these issues through a public health approach. Of course, we need our doctors, we need our specialists, but the danger of an over-medicalized approach sometimes is that, we lose out on the public health aspects. And I think that's the kind of balance we're trying to bring in through some of the policies we're looking at, also working with various states in India to set up a public health cadre, which can, exactly try and address some of these issues. So I think these are some of the, points I wanted to bring out on, I think, monitoring and evaluation. I'll just make a very quick, I'll just add a quick sentence or two, which is to say that, in our monitoring and evaluation, apart from looking at the normal, regular sort of output and outcome indicators that we do, we're also trying to make these more responsive to the communities themselves, more sensitive and more responsive, because, as I said, often people with TB, there's a lot of stigmatization. Then there's also the whole gender intersection. So we're trying to make sure that we also reflect indicators in our MNE, which can at least get us that feedback from the ground in terms of how responsive our policies are to these specific vulnerable and marginalized groups, as well as women who are dealing with TB and other such illnesses. So I think that's one big focus that we're trying to bring in as well. So I'll stop here. Thank you.
Thank you, Ruchi. So there's some very interesting points that you brought up, and I do remember and recall in one of the meetings that we had at and Dr. Devan would also remember that the nutrition package, from the Global Fund, the money that was allocated. Unfortunately, due to COVID, they couldn't reach out. And out of everything, that was one of the points which the TB patients really felt that they had been, that they really needed. The interesting point that you brought out of having a public health cadre to be able to boost and make sure that all that has been spoken earlier actually reaches the patient. So with that, I'll turn to you, Ridhima. In your opinion, so much has been said by everybody. There is the NTP program going. Do you see that there will be some course correction, some more elements being added to it to ensure that we can actualize 2030 as being the end date for eradication of TB? Over to you, Ridhima.
Thanks, Dr. Shabnam, and thank you to this wonderful set of panelists. So I would answer in this way, that even before the pandemic, we weren't fully there. We were still inadequate in a lot of aspects, and some of those points have already been raised by this esteemed panel. So, for example, mental health, early diagnosis, screening of patients, raising awareness, dealing with stigma, dealing with latent tuberculosis. So all of these things were in the pipeline before the pandemic, and then we hit this huge shock wherein a lot of our very limited resources, especially in the developing or the lower and middle income countries where TB is disproportionately sort of there, they sort of went towards the dealing with the pandemic, dealing with the shock it had. So I would say it's not a question, it's already happening. We already have interventions running so that there is, we can crawl back to at least, gain, go back to the gains we had realized. We have all read reports that, different reports will tell you different things, that we are 5 years behind, we are 12 years behind in different perspectives. But the reality is that we were always behind, and we were always making slow progress. And because of the pandemic, and this is a silver lining. The stigma, I believe, has been reduced because so many people got affected by COVID, that the stigma which occurs from a transmittable disease, that is sort of lowered down. At the same time, we are now into a new problem. We have a demand side problem as well. So the patients during this time of the pandemic, and even right now to a certain extent, there is a lack of willingness to sort of access clinical services because of fear that we'll catch some other disease, for example. And before I sort of talk about a little about what India is working on, or the globe is working on towards making these new steps or new interventions, I would talk about these different types of TB patients. So there is a TB patient who has not yet gotten the disease, or there is a TB patient who's already diagnosed, is in the middle of his or her treatment, and now cannot get drugs because we are in a pandemic. Then there are his or her household members, the community, and the reason we have so much of this disease, clustered in developing or lower middle income countries, is because of lack of nutrition, lack of sanitation, lack of hygiene, living in close quarters with each other. So while we have, there is about an 18% global drop, and in some countries there is an up to 40% or a 50% drop in TB notifications, we have not just lost a quarter of TB patients. We have lost a lot, many more TB patients, which were not really, they couldn't really come forward, they couldn't really access the medicines. And yes, so the very short answer is yes, we are on our way. And some of that is, the government of India and we at Clinton also, the way, whatever we are supporting in terms of mental health services, in terms of latent TB management. So now, according to the latest guidelines by CDC, we do not only focus on the patient, on the incident patient, but also on his or her family members. So the guidelines say that we have to at least counsel them and ensure as much as possible that the family members and the close community members, they can sort of be on preventative therapy, because while for the world it is 2030, for India internally is 2025. And I would just say that we are grossly inadequate. We have to invest more, we have to do more, and we have been doing that before, and we are probably going to do it in a more accelerated way right now, because we lost a lot on the way.
Right. Interesting perspectives. Dr. Sahu and the partnership people feel, yes, we can make it happen. Ridhima says, yes, we've gone back, but we are doing stuff to make it happen, to go forward and reach this piece. So, which brings me to a very important question, Dr. Devan. So, this pandemic of COVID-19, epidemiologically, do you see where this trend of TB is going? So aside for the fact that the pandemic came, as Ridhima said, Dr. Sahu, everybody said accessibility became an issue, diagnosis of TB took a back seat. Where do you see this move epidemiologically?
Thank you, Shabnam. See, first of all, I agree with Ridhima that our efforts were not exactly very up to the mark even before the pandemic. And the pandemic, the whatever mark it has made, which the points have already been highlighted. Nevertheless, I say, because in 21, as soon as we were having a decreased wave of COVID, as well as after the May-June surge of COVID, the efforts of diagnosis of TB, as well as treatment of TB, the fund allocation, etc., all those things reached near normal. We are not at all, there is no room for complacency. But all the efforts which are there, because India has, the plan that India has developed by 2017-18 is quite robust, even in terms of political commitment. The issues that need to be addressed, which need to be red flagged actually, which may be slightly different from the program, are number one, that it is at the primary level, screening level, active case screening to be able to find more and more cases needs further boost. And at the level of treatment, we of course need to develop better drugs, easier drugs, a drug regime which is simpler to follow at the peripheral level. And in the treatment and rehabilitation level, we should, because most of the efforts of people in Stop TB Partnership, WHO, etc., are limited to finding patients of TB, making them sputum negative and curing them. But we as clinicians, those who are working in TB institutes, know that there is a large pool of patients of TB sequelae. I am myself a cardiothoracic surgeon. I continue to deal with many patients who require TB surgery intervention, which is a high-cost intervention. So we cannot look at it only at low-cost interventions. There may be high-cost interventions needed in a significant number of patients. And number two, when mental health issues have been red flagged, I believe that right from the day we diagnose a patient of TB, he or she needs to be handheld for the whole treatment, he and his families also. And that requires a large pool of counselors who will help the patient to understand TB, how will they react to drugs, what problems they can encounter, and hope at the end of the tunnel when a possible cure can also exist, and yet be aware about the possible pitfalls which may occur. And every patient of TB needs to be completely supported from beginning to end. And as people from Niti Aayog or others are included, I think economics is very important. And first of all, we need to emphasize that any investment in TB is a part of the larger poverty alleviation program. It gives very good investment. Somebody from Columbia University calculated that $1 invested in TB care amounts to a return of $247 in terms of health care and economics of the society overall. And secondly, the TB care should be almost totally divorced from money. Every patient, because we had already in 2017 pledged that there should be no catastrophic cost to the patient. So that has to be ensured completely. It cannot be that patients and families, etc., or even governments and state governments should be made to pay a lot. It should be a concentrated program which takes care of all these needs. And this is almost has to be realized as an emergency for the society. and it is something which is doable. Why we all of us say it? Because it is doable. It's not something which is a utopian, which is in the realm of imagination only. It is doable. I'm sure Dr. Sahu and others, those working, they realize that it is doable. That is why it excites us so much. Thank you.
Thank you. I think you used that right word. It's an emergency. Amanda, you've heard all the speakers from across the globe with Dr. Sahu representing them, Ridhima, as well as what we are doing. What is it? Are there any learnings from Africa? Where do you see yourselves in reaching this goal of 2030? And anything that we can learn from you?
Thank you very much. You know, when Dr. Sahu was talking about the United Nations high-level meeting that was the last one held in 2018, I actually remember that our then minister at the time also signed to say that, you know, as South Africa, we are committing to ending TB, and we are going to, you know, ensure that all the resources and efforts are going to be, you know, put into making sure that that happens. And so what then happened is that in the next cycle, or rather the current cycle that we are at of the Global Fund, which is ending now in March 2022, we were fortunate enough as the organization I work for to be part of the organization that is actually implementing the Finding Missing TB Cases strategy. So you know that with that strategy came a lot of recommendations to say, you know, instead of doing things as we normally said, when Dr. Howe was saying, you know, Sahu said, let it be business unusual. So from 2019 up until now, we have been able to actually, I would say, test, implement a lot of innovations that I believe, you know, have actually contributed to finding ourselves where we are. Obviously, we are still very far from even reaching our targets, our TB case notification targets, because, you know, South Africa is one of the 30 high burden TB countries that we have, and we account for about 3% of the global TB cases. What also contributed as well in how we implemented the Finding Missing Cases grant was actually the first national TB prevalence survey that we had in 2018, where we realized that actually there's a very high TB burden in males more than females, and especially between the ages of 35 and 44 and 65 years and older. And a higher proportion of TB was also detected amongst HIV negative individuals, with most of them reporting no symptoms. And then also a delayed access to services among the youth, which is the ages between 16 and 24. And so what we've actually done then over the past 2-3 years is we've actually intensified case finding. And in that, we have actually been able to see that, you know, the current healthcare system that we have is that every single person who attends a healthcare facility will be screened for TB. And that is actually calculated to say out of the facility head count that you have, we're actually also using the 1990 target, but for TB, to say at least screen about 90% of the people that come to your facility every single day. However, when we looked at the baseline data, we realized that as much as facilities would have a very high TB screening rate, but when it comes to clients that are confirmed, or rather that are presumptive of TB, we would look at like 2% of the head count, and yet our target in the country is actually 10%. So what we did is we sat down and we said, okay, let's implement the Finding Missing Cases strategy so that we can be able to see, are we really going to be able to find these TB cases? And I am happy to report that actually having done that, we have actually picked up cases. So what we do is we make sure that all of these targeted high-risk groups, whether they have got TB symptoms or not, we actually make sure that we collect sputum so that they can be tested. So we focus on our clients that are newly diagnosed with HIV, and we focus on our people living with HIV, especially those that are virally unsuppressed. We also look at clients who have had previous TB in the last 2 years. We look at women that are pregnant, and we test them as well at their first antenatal care visit. We follow up the household contacts of our TB index cases. And what has been good about this grant is that for the first time in South Africa, we have actually had the digital chest X-ray that is screening for TB in communities and in facilities. And we actually use the digital chest X-ray where we have used data to map out a TB hotspot so that we can be able to go with that community with some level of baseline data done. And we've also actually started intensifying the use of urine LAM so that we can be able to test very ill patients, because what we found as well is that most clients would be diagnosed or rather would be admitted in hospitals for TB. So which means that, the primary healthcare interventions were not done very well. So what we've done now is that instead of making sure that TB is tested at that higher level, we've actually also included that. We've also found a lot of TB amongst clients who are admitted in hospitals, where we have nurses that do the rounds and do TB screening in clients that have actually been admitted in hospitals that would have been missed. And we actually picked up a lot of diagnoses in that. So through those strategies, we have actually been able to find TB. I'm happy to note that there's been a lot of discussion in the panel around TB prevention and adherence, because one of the things that we successfully did actually was provision of nutritional support for our drug-sensitive and drug-resistant TB clients for treatment adherence. And I mentioned earlier as well the psychosocial support for treatment readiness, and also continued as well throughout the treatment journey. We also got an opportunity to be one of the organizations that piloted the introduction of 3HP as a shorter regimen for TB preventative therapy. And this has actually assisted a lot, because the current regimen that is being used is actually over 12 months. But now with 3HP, there's a shorter regimen that can actually be taken over 12 weeks, which actually assists us for our clients living with HIV that do not have TB. We've intensified also INH preventative therapy for children, especially those that are household contacts of TB index cases and our children under 5. So as the country now, where the priorities are is really to have that targeted universal TB testing for high-risk groups so that we can increase diagnosis, and also to improve and increase the uptake of TB preventative therapy. We also have a self-screening app as well that we have also just developed, and this is actually accessed by all communities. And also the diagnosis that we have that we're using actually through ULEM and the digital chest X-ray. So as mentioned earlier, we are still very far from reaching our targets. But however, we do have, all of these innovations that I just mentioned earlier on how we have actually implemented the Finding TB Missing Cases strategy and are able to find TB cases. And most importantly, keep them throughout the treatment journey and have good outcomes at the end. So I think, just like Dr. Sau mentioned earlier, the urgency now is everything has got to be done now, and it is going to be done in an innovative way and in a way that has not been done before, because we really need to end TB by 2030. Thank you very much, Dr. Singh.
Thank you. Thank you so much, Amanda.
When I
Dr.
said-
Meena,
Yeah.
I was coming to you, sir.
Yes. Good afternoon. If we want to really eradicate the TB, the important thing is the prevention is better than cure. So especially we are focused on the awareness and screening part. It's very important part. And because of the Ayushman Bharat, Pradhan Mantri Jan Arogya Yojana, previously the females take very less treatment. But now we take analyze the beneficiaries. More than 50% is the female. And it's a good sign for the treatment of the females. So it's a very important. And related to the TB treatment, the nutrition is also very important, because the treatment is not not a one part. But if you have the proper nutrition, then you really cure the TB and other prevent the other infectious disease also. So first important thing, the awareness is very important. Screening of the TB patients is also important. Ability hospital is also there, so the female awareness is increased and the female treatment is also increased. And the nutritional part is very important, because when I go one hospitals and I see that one patient is admitted since the 7 to 8 days, and when I analysis that the treatment is going properly, but the nutrition is not going properly, and that's why it's not cured. So it's very important that nutrition is also important with the treatment of TB patients. So I think so. Both of the is very important.
So if we hold that thought, Dr. Meena,
Yeah.
given the work that is being done by the NDHM, is there any thought being given to how we can use this platform? Like Amanda mentioned, a screening, an app for TB patients. Are you all considering things like that, which could be leveraged into the system for early detection?
Yes. We just a discussion with the TV divisions that they are prepared one package of the screenings, and after they prepare the package of the screenings, then we will allow in the NHA platform also.
Okay.
Yeah.
So there is, I mean, as far as research is concerned, as whatever we do will require the digital platform, and innovations are going to come from there. So I'll move to Dr. Sahu. Dr. Sahu, you have a very powerful conglomeration and support from governments as well as the private sector, right? And time and again, everybody has emphasized that let us pick them up early. Let us pick them up early. So what is it that, if top of your mind, one or two areas you'd say should be the focus to realize 2030?
So let me build a bit on what other speakers talked about. Moving towards 2030 to end TB, we will need, as I said, early diagnosis, and many people talked about it. And that should happen with a new mindset. It is not just okay for us to wait for people to turn up very sick in hospitals. We saw in COVID how people who are otherwise healthy got tested, even outside the health system. We saw how their results were, the turnaround time was great, that they can even catch a flight. It was so timely. So how can we do testing and screening with new tools on TB and do it at scale? For India, a country like India, you need scale. So that is very important. I'm very encouraged to hear from Dr. Meena about the package for screening. Let me remind everybody that the prevalence surveys done, including in India, repeatedly show us that up to 50% of people who are bacteriologically positive, confirmed with the prevalence survey, did not report symptoms. So there, the screening becomes very important. The tools we currently have for screening, as I mentioned, has evolved. The best screening tool currently we have is X-ray. X-ray used to be a big room. You go very limited. You get the result after 2 days. It's no longer like that. It's a small machine. You can put it in the community. Very low chance of exposure. The result turnaround is 30 seconds. Artificial intelligence result. And if you need a further bacteriology, it will indicate. And the bacteriology test should be a molecular test. There is no reason we should accept in 2022 a sputum microscopy. I must say that a lot of people globally, majority of people globally detected with TB, WHO reports 2/3 actually got diagnosed last year with sputum microscopy or clinical. That should not be acceptable. In a country like India and globally, also South Africa has already done this. Actually, we should credit South Africa because everybody who gets diagnosed with TB gets a gene expert test. So that should be the diagnostic, because if you do such a lot of effort to screen people, and then at the end of it, you have a very poor diagnostic tool as sputum microscopy, because it is cheap, you lose a lot of people. It has a sensitivity of only 60%. 40% you will not detect. It will not tell you about the drug resistance status. You cannot select the correct regimen. So very important to do the screening, but screening with the right tools. And I must say, Dr. Singh, your comment that there are in the pipeline now a number of non-sputum based tests coming, and some of them exist. I think Amanda mentioned LAM, which is a urinary test, but it is effective currently in people living with HIV. But there are more tests also coming in this area. The second thing I would emphasize is doing prevention at scale. So let me add my voice to many speakers who said about undernutrition. This is, if you look at the total TB globally and also in India, particularly in India, the proportion of TB that can be attributable to undernutrition is the maximum, much more than HIV, much more than any other illness. It is undernutrition that is driving the TB in India, in Southeast Asia mainly, also globally. But in India and Southeast Asia, a lot of people in India have actually done good work on this. There is a trial also ongoing. I don't know the latest about it, the Rason's trial in Jharkhand, I suppose. So there are a lot of learnings to be done in that area. And I must emphasize one point. It is not okay to give nutrition only to TB patients. That's important. But we need to go beyond and provide nutrition to those who are undernourished, who are at risk of developing TB. These may be the contacts of the TB patient or other people in the community. And I think in the context of prevention, very important to look at TB preventive therapy. The tools are available. Amanda spoke about this 3-HP regimen, just 12 doses, and you are protected against TB if you are infected. So TB preventive therapy needs to be scaled up. And India has done good research on vaccine. There are some findings from the BCG recombinant trials. Other places we have also any other pipeline vaccines that are coming. We should look forward for a good vaccine to be scaled up. So if all this is done, we put it together as search, treat, prevent. So a search part is very important. It's not just diagnosis. Search, treat, prevent, STP. So if that is done at scale, you can end TB. And what will surely not end TB is business as usual to continue. The status quo will not end TB. That's very clear. So we have to change how we address TB. We have to increase funding for TB, which is very important. And I must say that there is a very good opportunity now. Many speakers highlighted some learnings from the COVID pandemic, which perhaps makes us in the TB community think about things that were pre-COVID thought as not feasible, is currently feasible. The research and development, one year for vaccines to be researched, a few months for new diagnostics to come and get scaled up, the airborne infection control and prevention that TB has been doing at very low scale. Now there's an opportunity to scale it up across the health system, across congregate indoor settings. There are many other things that we learned from COVID on how to pass on the fruits of research quickly onto the patients. The regulatory framework in this context is very important. And I must end by saying that ending TB is a whole of the government and whole of society responsibility. The public sector, as well as the private sector, and the community leading in all the interventions that are needed. And Dr. Singh, just to highlight that there is also a ending TB in workplaces initiative from the World Economic Forums. Stop TB was part of the conception of that initiative. I think CII is also part of it. India can, the private business can do a huge lot of work to end TB as well. So it's a whole of a society responsibility, and we must act. We must act now. Thank you.
Thank you. You're absolutely right. Very much part of the process to stop TB from the business perspective. So we, as you know, we have tools, we have apps which we are disseminating amongst all our stakeholders. But you're absolutely right, it cannot be business as usual. And the velocity of change and innovation is there to support making things happen. So with that, I'll move to Urvashi. Urvashi, from a policy perspective, as Dr. Sahu said, do we see some change come that you are anticipating, or is the Niti Aayog working on some of the areas which have been spoken of so far?
Yeah, so I think, I would just reiterate some of the points that I made earlier as well, that, we do need a holistic approach, a public health approach. And I think in that, if we can get these public health cadres, which we are trying to, set up in different states, that can certainly make a big difference. Also, can our health and wellness centers, because, as we know with Ayushman Bharat, the insurance is just one part of it, but the other very important pillar are the health and wellness centers, which are to be set up across the country. And the whole idea is that these look at promoting health and well-being in a much broader context than perhaps our primary health system has done in the past. So I think there's a lot of potential there as well. If we can have public health cadres, we can actually start making sure that these centers can operationalize everything that they intend to do on paper. So I think that is one big push that we are making. But I think the other is definitely on integrating all the stakeholders, and I think that's also come up. Whether it's the local communities themselves, women's groups, self-help groups, but also then the private sector, because in India, as we know, the private sector is not necessarily just the organized or big large corporate hospitals, but actually much of the private sector is informal. So how do we really integrate them in a meaningful way with our TB eradication efforts? That is something that again, there's a lot of progress being made. There's a lot of interesting pilots. There's some good practices that have emerged. But we need to scale this up. We are clearly well beyond a stage where pilots would suffice. We need to really take some of these learnings to scale. So I think that would be the other big piece, is engaging stakeholders of all kinds really in this effort. And I think finally, as has also been said by others, our investment into innovation, into research and development at all levels, whether it's screening, detection, diagnosis, or actually treatment, which is better tolerated and more effective, shorter regimens, etc. I think that is something where we also need a public-private partnership. I think there's no doubt that governments need to increase their investment in this space, but we also need a lot of private investment to flow into this area to really catalyze some of these critical innovations. So I think those are three points in summary that I'll make. Thank you.
Thank you, Ruchi. So, Ridhima, to close it up, it all comes down to we have fantastic global learnings. We are getting a good handle and sense of things can be done with speed. Research is there, but money is also, it's there, but it's not there, right? So how do we galvanize this? What are your thoughts on it?
There's so much to say, but there's also so much already said in this panel. So I would go back to what Dr. Sahu said. So essentially, I would say what he was saying was that we need to take a health systems approach. We do not only stick to clinical diagnosis. We do not only stick to, let's say, patient management. There are so many. We have to invest in effective forecasting of how many drugs might just be required in the next quarter, small steps. We are already focusing on utilizing digital tools for patient management, but at the same time, we need to ensure that there is a person who's following up with the patient and his or her family members so that they are on track, the adherence is on there, so we do not really slip into the drug-resistant form of tuberculosis. And Dr. Meena said a lot about diagnosing in females, because in females there is There is a huge, shortage of early detection in terms of extrapulmonary cases, in terms of it's frequently misconstrued or misunderstood as maybe there is a challenge in the fertility treatment going on, and you find out about a year later that it's actually tuberculosis. So that aspect. But since we're talking about investments, all of this would sort of go towards the global target of sort of eradicating or reducing tuberculosis. But the problem statement is that 1 in 2 households are suffering from catastrophic health expenditure. And when I say catastrophic health expenditure, they're spending at least more than 20% of their household income in supporting their treatment, in supporting their families. They lose their jobs, so on and so forth. And in terms of pure statistics, because I have to say some numbers as an economist, against the target of 13 billion USD spending, we are only spending about 40% of that money on tuberculosis. So I believe that we definitely need to take a health systems approach, take into account all kinds of different solutions, vendor management, drug forecasting, drug availability, transportation services, early detection, innovation, research and development, so on and so forth. But it's also about prioritization, because if we could prioritize that this is what needs to be done, which we saw overwhelmingly during COVID, right? It's like the space at which we found solutions. It is, we suffered a lot, but it is amazing. It is amazing that in this crumbling healthcare system globally, we sort of rose up and supported each other. So I would say there is that prioritization which is there, and we just need to sort of keep up the momentum, and which would ensure that we keep up the investments and we keep up the right effective spending as well. Not just say that this is the amount needed to invest, but actually spend that money. So I'll close at that.
Thank you, Ridhima. So that's a very optimistic note to end on, in which it's given a feeling of togetherness, where we've all been able to put our hands around COVID. I'm sure we'll be able to keep to our deadlines, whether it is 2025 or 2030. And we're all in this together, sink or swim, and we'll make it happen. We've done it before and we can do it again. So thank you so much for all your very wonderful insights and being a fantastic panel, all geared towards an outcome. Thank you so very much.
Thank you very much. Thanks to all.
Thank you, everyone. Thank you so much for letting me participate.
welcome to the National Virtual Forum for Tuberculosis Awareness, which is being organized by Voice of Healthcare and being supported by Viatris Pharmaceuticals. I think we have a pretty exciting panel today, some of whom I know personally from previous associations, and many of them I haven't met over the last 2 years. So I'm personally very excited to see all these people on the screen. And of course, just given sort of the background for our panelists today, our topic is going to be the usage of digital health tools to essentially, control tuberculosis. So as many of you would know, 24th March is World TB Day. And TB, of course, is high on the national health agenda for both the Prime Minister Modi, as well as private industry, as well as not-for-profit and other public health stakeholders. It is one of, if not the largest infectious disease killer in India and world over. And so, of course, it is something that actively, it's a multidisciplinary approach between many stakeholders and something that is of very, very big importance for the country. So without further ado, I'm actually going to go to our panelists themselves and let them introduce themselves, as well as the organizations they're representing. I'm 𝐓𝐁'𝐒. I represent Cepheid Diagnostics. I will also be the moderator of this session. And so I will now go to perhaps Dr. Vedam, and then Naresh, and then Dr. Prapti to introduce themselves.
Yeah. Hello, everyone. I'm Ram Prasad. I'm currently the Chief Executive Officer for 𝐓𝐁'𝐻 in India. Take care of the complete diagnostic business. We're based in Bangalore. I've been founding member for 𝐓𝐻, and it's been about 7 to 8 years I've been with 𝐓𝐻. And we are the market leader in genetic testing and also genomic research services across the country and this part of the world.
Excellent. This is Naresh Hasija, and I have 20 years of experience with the healthcare industry. Majority of this is the pharmaceutical industry. So present role, we are getting into disease management, where we would like to be offering solutions, not only our treatment, but go to market for other solutions like digital adherence tool, like maybe some certain diagnostic solutions, as well as other technological solutions to public health.
Good morning, everybody. I'm Prapti Jaiswal from 𝐼𝐈𝐓𝐇. I'm a molecular and microbiologist turned entrepreneur about a couple of years ago because of this 𝐾IA called translation. We wanted to translate our research acumen into real-world application. And that's when me and my co-founder built 𝐼𝐈𝐓𝐇. We marry genomics with artificial intelligence to provide precision diagnostics that would essentially enable physicians and clinicians to make more data-driven decisions.
Thanks, Dr. Prapti. Thanks, everyone. I do believe we will be joined with a couple of other panelists later in the session as well. But to kick things off, I think, I see Dr. Amit is just about to join. So perhaps, hello, Dr. Amit, you're very timely joining the discussion, because we were just going through the introductions. So if you could just introduce yourself and the organization.
Yeah, thanks, Karthik, and thanks for calling me at this particular stage. Apologies for the slight delay. I am Dr. Amit Kharath. I am one of the co-founders at 𝐷eepTech. I'm a radiologist by profession, been practicing for 20 years. I look after the domain-related activities at 𝐷eepTech, which includes the AI models as well as the validation activities. So that's a very short introduction about myself. Over to you, back, Karthik, again. Thanks.
Thank you. Thanks. So to kick things off, I think, as everyone would be aware, India has set itself a really ambitious target, right? Which is to eliminate TB by 2025. And that's a full 5 years before the SDG targets, which actually stipulate that countries will try to eliminate TB by 2030. that has actually been backed by the government. All of us here on the panel are very happy to see that the government has increased its budget allocation for the TB program. So things are in the right direction. But I think maybe just to kick things off, we do know that adherence to drugs, right? Even once the patient gets diagnosed and then, starting to take the drugs, that is a long journey, right? And perhaps, all of us have done it. We're barely able to complete our course for antibiotics for 6 or 7 days. And here we're asking patients to, continue drugs with 6 months, 9 months, sometimes up to 2 years, right? And so just to kind of go into adherence, right? How do you make patients adhere to treatment? Perhaps since all of you are in the digital health space, I'll go to Dr. Vedam and just get his thoughts on whether there is any space for digital adherence tools to really improve adherence and thereby improve treatment success rates.
Yeah, thanks, Karthik. I think the DAT digital adherence technologies are becoming very interesting. We all know about the impact that these things had on the digital technologies had on various sectors. And one of the sector where they could be or potential impact has been how to make patients or individuals monitored for the adherence for the treatment protocols. We all know that we had a DOT program, in-person DOT program. There was good improvements over the nationwide program, but as you know, it's not easy to do in-person programs, not scalable processes, needs large resources across the country, especially when there are patients in the remote part of the regions. So last few years, we have seen that digital adherence technologies have become very handy, at least to an extent that they are very easy to do done, very scalable. Today, everyone carries at least not a smartphone, at least a mobile phone, a hand phone with them. You can send an SMS to them. You can do a voice call. You can do a toll-free calls and ask them to return back the call. So there are various digital adherence technologies which are coming up. However, to be very if you look at into last few years of RCTs done on the DAT and how they have improved on not just on the treatment adherence, but on the outcomes of the treatment, whether a number of cases have a treatment, individuals have got rid of TB with proper treatment or not. There have been at least about half a dozen RCTs done. I think several RCTs, especially in Africa, are being done now. Results are yet to come out. The results have been a bit of mixed results. Some of the outcomes have been pretty good, improved outcomes using digital adherence technologies, especially one from China has been improved outcome. A couple of them from Africa showed that there has not been significant improvement on the outcome of it. But having said that, there are two aspects we look into it. One, where there is an impact on the outcome, which is very critical, which is the reason why we use the different methods to monitor this. And the other thing is the ease of use and the scalability of the technology. So the second part of it is not a difficult thing. That's everybody knows. It's easy to scale up. It's easy to monitor. It's easy to check everything. You can do much easier than what we used to do as an in-person program. But what we need to wait and watch is all the RCT results that come up in the next 1 year or so as to are they really effective in the final outcomes or not. So that's something that we need to really look at it.
Thanks. Yeah, you make an interesting point, right? I think wait for the results, wait for a definitive conclusion, because there is a cost to these technologies, right? Even implementing them for the program, even for the private sector. And perhaps that's a good segue to go to Naresh, right? Because as a pharmaceutical company, perhaps they've tried this in other disease areas and with other therapeutics. And so, Naresh, I'd love your thoughts on sort of adherence of drug technologies, as well as, you have kind of a unique vantage point, right? To really look at this as a universal sort of lung health intervention or a universal lung health program. And, the innovations that all of these companies represent, how do they essentially play a part? So really two questions for you.
Fine. Thank you. So we being a pharmaceutical company, I think, so our core goal was to make sure whatever treatment we are providing, it has to be adhered. And our drugs were in a space like MDR as well as XDR. So it was more relevant, particularly in tuberculosis and in NCDs. So now also, I think we are looking into some solutions which can make sure there is a good adherence. So what we did is, like, we wanted to understand this space in a bigger way. So what we did is, like, we did a hackathon here in India, and to our surprise, I think that we have huge talent in our country, where people came up with fantastic ideas to innovate this space very well. Like right now, if you see in tuberculosis space, you have 99 dots, you have care dose, and you have mom's box, I think. So there are few solutions which are trying to change this space and make sure adherence is done. As you rightly said, Karthik, I think it is difficult for us to follow 5 to 7 days antibiotics, and here patients are taking few months treatment. So a big, I think somehow all of you are from startups, and I think you can help us to innovate this space. We guys are, again, go to market. We can tell you the problem statements, and that's all.
Perfect. Thanks. I'll actually go to Dr. Amit, and I think, maybe bring the sort of discussion more towards diagnostics, right? And just get your thoughts on how the interventions and the innovations within diagnostics really will help India achieve its goal of controlling TB by 2025. And so, any specific examples you'd like to share with us, Dr. Amit, as well?
Certainly. Thanks, Karthik. I think it's a unique, today's session is really indeed unique, because we have all the stakeholders here in terms of the startups working in different aspects of the TB detection elimination project. The idea here is, like, we are just one of the kind of supporting pillar in this initiative from the diagnostic space. And I think innovations in all space, without AI, with new technologies, smart technologies, IoTs are going to change the TB landscape in the country, and we will be able to achieve the goal of TB elimination. Considering specifically related to how AI-based TB screening project has been done, we have been doing this project now for the last 3 years. We have screened more than 200 clinical programs, and we are not only working with corporations, but also with USAID and other organizations and NGOs across at least 4 to 5 states now. And what we see that as the TB screening process could be accelerated using AI, we just accelerate one pace in this entire complex scenario. So whatever changes are brought in are going to amplify the results at the end, is what could be one of the end results. Now, the AI-based screening tools, whatever are there, and we are not the only one. There are many other companies working in this space. And the good part is that all work towards the same goal of ensuring that the TB screening happens really quickly. And I think with the conceited effort, continuous effort by all of us, I indeed see that we will be able to achieve this goal of TB elimination very soon. Thank you so much, Karthik.
Thank you, Dr. Amit. And so, I was particularly excited when I was seeing the panelists for today, right? Because so many of you represent sort of essentially startups that are, really taking AI to scale, to making it clinically relevant beyond sort of research labs. And all of them, I think, are essentially founded by, Indian capital, Indian sort of know-how. Founders are Indian. So that's really something nice to see, right? And I was also happy seeing a female panelist who's also, sort of leading a startup of her own, also in AI. So I'll go to Dr. Prapti. I think similar space, Dr. Prapti, that you sort of function in, but I'd love to get your thoughts as well. I think safe to say, last 2 years, we've kind of seen a setback in the TB program for some controllable reasons, for some uncontrollable reasons. But would love to hear your thoughts on how perhaps your own organization is helping in this space.
Yeah, most definitely, Karthik. I think, the last 2 years have been, the most most unprecedented times. It's with the risk of sounding banal, it's all because of this one minuscule virus. And these pathogens are notorious, whether they're causing COVID or they're causing tuberculosis. They're evolving continuously, they're evading our drug attacks, and the rate at which they evolve is way faster than we can do drug development. So it's about time we exploit technologies and really channel them and wage war against these pathogens, to start not just playing catch up like we have been in the last 2 years, but now start staying ahead in the game. We have to preemptively prepare for, God forbid, the next pandemic. We cannot fuel this kind of rampant, attack, so to speak, from these pathogens if COVID is any testament to what we have seen. And in a pre-COVID era, TB was the most lethal infectious disease globally. I've harped on about it, and we really need to get our act together, exploit technologies that are cutting edge to preemptively take care of ourselves, of humankind, essentially. So I definitely believe that our implementation of cutting edge technology will help us win this race against pathogens as they evolve continuously. We real time not just play catch up, but start staying ahead in the game from them. And two, at a larger scale that my co-panelists have been talking about, I think access and equitable access to all at scale is very, very important. But that being said, there has to be caution. Things like antibiotics and Google Baba and self-prescription are a whole different ball game. So while scale is important, it has to be done with caution, especially when antibiotics are involved, because antimicrobial resistance is a whole different demon that essentially just plays into this gamut of infectious diseases wreaking havoc on mankind.
Right. Thanks, Prapti. That's a interesting, really take, right? And I'm glad you kind of bring up the sort of negatives or all the things that we're told that when you get too reliant on technology or when AI gets too predictive, right? And we've all been there with Google and things like that. And so there is a fine line there. And I think this is something we'll explore a little bit deeper in the session today. But changing gears, I think a lot of you mentioned the innovations. I personally, as a person, I like to look at the glass always half full, right? And so COVID, a lot of research has been done, right? And also, of course, across the globe, but also I think within India, right? And we're seeing a lot of interesting research projects. Some of the findings from those research projects come out as well. And, part of it has been at the cost of deprioritizing other diseases, including TB maybe, right? But I think, if I was just to go back to Dr. Vedam, right, because you are, as an outfit, represent a fairly sort of research-based approach, right? To just get your thoughts on this, do you see it at the cost of TB progress, or is this something that you think is symbiotic, that we've done work in COVID, we've done sequencing, we've done all these other things, and it'll help us in TB as well?
I think COVID has been an eye-opener in one way for many of us, including at government levels, as to why surveillance at the genome level is very critical. But at the same time, COVID has become sort of a bottleneck for many other programs like TB programs. We have seen significant downfall in some of the programs that we were doing, not just on the DNA-based testing, but also in doing some of the large camps that we do, identifying pre-tuberculosis patients. So all these programs were completely stopped. So, but I think it's a good lesson for at the public level that we should come up with plans in such a way that even some of the pandemics come up, we should have our own disaster management policies where other programs shouldn't be stopped. And as you know, yes, COVID has been a big problem. It's the first time this virus is coming up, but tuberculosis has been much bigger threat for us from last 300, 400 years. And those programs getting completely reduced is something that is not acceptable. I think we have to ramp up the program significantly, use all the resources available. And on the surveillance part, I think Naresh is there, Prapti is there. Somebody said in one of the press release last year when we published our whole genome sequencing from the sputum directly in tuberculosis, they said MedGenome has a silver bullet but no magic gun. So we are looking for a magic gun. So it could be government, it could be large industry, it could be pharma partners, it could be anybody. We are willing to work in a non-profit way to see that at least as a major use case scenario as to how this will impact across the country.
Thank you, Dr. Vedam. That actually sets us up for a good segue into talking about the role of the private sector, right? And you mentioned there's of course the government, but in India, I think a large portion of our healthcare is delivered by the private sector, right? And that's here to stay. I don't think anybody can will it away. And when the private sector, of course, in some sense, we are all part of the private sector. But then, when the government thinks about it, they think about clinicians, doctors practicing in the private sector, labs and diagnostics, chemists, pharma companies, so on and so forth. So, Naresh, I'd love to come back to you and get your thoughts on, engaging the private sector, right? I think India has done a tremendous job in the last 5 or 6 years, but a lot more needs to be done, right? And as a pharma and a diagnostics company, you do have experience dealing with both, right? You have experience dealing with the government as well as a very large private sector, right? The doctors and clinicians. So would love to get your thoughts on what we should be doing. What are some other ideas that you'd like to see the government pursue or some other funders pursue?
Perfect. Thank you. See, basically, right now, what we should introduce or what we should all really work with government very closely is, which we at our level are already doing it, is end-to-end disease management. I think this is one area where we see there is a huge scope. Right now, when I meet a lot of startups here in Bangalore, and when we see that it is difficult for everybody to go and pitch in with government. So there should be a comprehensive solution, which maybe a large pharma or maybe a large diagnostic company can offer that comprehensive solution to government. So if this is what I believe, and this is what we are planning to propose. Maybe very soon we are in discussion where all the starting from primary screening till treatment outcome, can we provide a comprehensive solution? This will plug in your all solutions what we are talking today, from primary screening, confirmatory tests, your genomics, and your AI solutions in primary as well as in confirmatory, and then of course the treatments. So treatments, and then treatment adherence, then treatment outcome measurement. So this will be a comprehensive thought, and this will give I think that this will connect all the dots what we see which are missing sometime in government when we work with them. So for us, we have done a lot of public-private partnerships with government where we provided first access of our MDR drug, where we gave them free access of the drug for a time. And I think based on the data, then drug was included in the program. It was delaminated. And now we are doing a big, large project with help of Union and CTD, where we would like to provide this access to corporate hospitals, because there are patients of TB which really don't want to come to public, and they are very vocal about it. So with the help of Union and CTD, we are trying to develop a digital solution, and this solution will be owned by CTD, where they will decide what treatment protocol has to be given to this population, because that fear of drug misuse will be in control if it is if it is done under the supervision of Central TB Board. And there are some more where active case finding and some screenings we are doing in different places. This year we've been taking up to a next level where we will be partnering with people like you and taking your solutions into MMUs, and we'll be doing a lot of pilots across India. So this is the goal. And one thing is very clear, we are also with the mission of Prime Minister, where we would like to work closely to eliminate tuberculosis by 2025. Thank you. Over to you, Karthik.
Thanks, Naresh. It's really nice to hear a pharmaceutical company talk about a complete solution, right? And I think even I've been guilty to that, right? Sometimes we become a little myopic in our approach. I work for a diagnostics company, so often we think about how can we get the government to use more diagnostics, right? But overall, in the end, TB is a public health problem, right? And in the end, what matters is, are you finding patients, treating them, eventually getting them to cure, right? Diagnostics is a very important part, but it doesn't stop there, right? So very, very refreshing to hear that. I think, your experience and your company's experience dealing with the private sector will be really helpful for the government, right? Because as they formulate an approach there. Anybody else who would like to weigh in before we get into another aspect in the session? Perhaps Prapti, would you want to say something? I know in your own organization you're working with some private stakeholders, but anything else you'd like to add here?
Yeah, most definitely, Karthik. This is very early in the development of Aarogyā AI that we realize that it's going to be not just a public sector play or not just a private sector play. And we've, like you mentioned, we've got investment from Illumina, which is directly the largest genomics sequencing hardware company in the world, San Francisco Bay. So we were exposed to this Bay Area startup thought process that really helped Aarogyā AI. But focusing on the point here, which is Naresh, what he just talked about, and what you also clearly alluded to, Karthik, was the end-to-end problem solving. So while folks like ourselves can, probably plug into, we're like pieces of the puzzle, and all of it has to come together in the end to make that bigger picture of eventually, meeting the elimination of TB by 2025, 2030 as aligned. So we're all little cogs in this big, machinery to put into play and progress into towards eliminating that. So super excited, and I'd love to connect with you, Naresh, to see how we can contribute to this very end-to-end system that you've been attempting to put together, because drug misuse is one of the biggest reasons why we built out Aarogyā AI.
Excellent.
Thanks, Prapti. I think if we are seeing Bay Area capital and innovation capital flow into TB, I think we must be doing something right? If that capital is finding some value in pursuing TB research and TB interventions, then there must be something there. I think so. We're probably on the right track. I think we'll take a little bit of a pivot, and I'll go to Dr. Amit again. I think part of what we'd all assumed when COVID hit us was that there may be some changes to the epidemiology of TB, right? Maybe around transmission because of the lockdowns, because of mask wearing. I think maybe it's still too early to say exactly how the epidemiology or prevalence of the disease has changed. But Dr. Amit, I'd love to get your thoughts on anything you've seen or anything you anticipate or any research you've been part in. Tracking the epidemiology of TB.
Yeah, I think Karthik, last 2 years, as we all know, has been spent significantly on COVID-related research. TB was something which was always happening. We were focused, and suddenly everything pivoted towards COVID, and how TB and COVID kind of coexisting, where we are finding a lot of community-acquired pneumonias, which could be probably COVID. And we were seeing that the rate of asymptomatic people having lung involvement of COVID and was around 3 to 15%. But specifically, if you ask me about research as to how many of these were existing tuberculosis patients, is something that we need to really dive a little bit deep and come back on those particular kind of metrics. But we have seen that in TB screening programs, as and when, as Dr. Vedam rightly said, that almost all these programs came to a significant halt. But we observed that in the Greater Chennai Corporation area, that where we have been working for the last 2 years, some of these vans were still working, supporting whatever initiatives, and many of them were pivoted for COVID screen. And here we did encounter that we are getting mixed data, kind of patients with COVID as well, patients with TB as well. And here we observe that the rate of infection changes depending on what peak of the COVID we were in, at what particular state India was going through at that particular period of time. Saying that, I don't see that we are very early to or drive any conclusions whether what's the kind of spread of tuberculosis, or will it alter presence of COVID, whether it will kind of potentiate or it limits, or in some way is protective. I think it's too early from my side, from the diagnostic side, to come or make any comments on this. But it's only time will tell. More information coming from genomics and other data will definitely add more value to this. So that's a few of my observations in the last 2 years.
Dr. Vedam, anything you're seeing in your lab or in your experience over the last 2 years?
We've been working last 4 years, 4 to 5 pre-COVID onwards. We've been working. We came up with our proprietary assay chemistry where we directly sequence the TB genomes from the sputum, and at a pretty high coverage and full-length genomes we do it. And we processed about approximately about 2,000 to 2,500 samples, direct sputum samples, and results have been fantastic for us. And we've been working with different organizations, including FIND and a couple of universities and academic bodies. We are extending these studies into non-sputum samples, which includes cerebrospinal fluid for detecting TB meningitis, and also some other. And we've been increasing not just specifically for tuberculosis. We are working on non-tuberculosis mycobacteria. We're working on some other tuberculosis like bacteria, which are part of this, expand the scope. Doing some lineage studies for surveillance and all that. So a lot of things, and we reduced the cost significantly. When we started off 4 years back, the cost was about roughly used to cost 15,000 to 70,000 rupees for one sample to come up with full drug resistance, which includes pre-XDR, XDR, MDR, and new variations. But we've reduced it now by 50%, and we hope to reduce. Depends on this. If the scale is large, the cost will significantly come down. But again, as we are a commercial company, we're not funded by government, unfortunately. So we have to look into ways and means as to how we come up with projects where we can scale it up in a large way.
Thanks. Yeah, no, I particularly like the fact that the cost of these, panels and these diagnostics are coming down over time. I think a 50% reduction is really sizable, and we hope that that'll really decrease in the future. I think throughout this session, we've talked about the role of the private sector. I think we also need to talk about the role of the government, right? I think in all our organizations, because we are working in TB, in some or the other way, we interact with the central TB division, or maybe some of the state TB cells that are part of the state government health machinery. I'd love to get some thoughts on perhaps what the government could be, not saying doing better, but how could they be supporting your own organization or your space of research a bit more? I think safe to say the government's done a lot, but they could probably be, a little bit more forthcoming and perhaps really look at some of these new innovations. So, Dr. Prapti, do you have any ideas? I'd like to think that there would be some government stakeholders that would also listen in on this, so they could take something away from this conversation.
Yeah, it's a tricky question, Karthik, because we always want more, and I think there's always more that can be done. But I think one of the greatest things about the Central TB Division is that they have been very approachable. unlike how you would imagine a government body to be. So one of the best things I think has been that they're approachable. And there is definitely intent because of the will to eliminate TB by 2025. It aligns with the national elimination policy. So those are the big positives. So there's definitely intent. They're approachable. I think if I were to wish for something, I would wish for things or decision making to move faster. I do understand that we have to prove, like a startup like myself will have to prove some credibility, and that can come through peer review before the government can implement that. That is very clear to us. But we would really, like, if we were to wish for something, we would wish for things to move faster, because we're all aligned, as it has come out in this panel. We're all aligned towards the same goal, and that shared purpose is always very strong. So for it to be channeled more effectively, I believe if we were to move faster, while I do understand the constraints of bureaucracy, it would be ideal if we could move faster to get stuff done together.
No, that's I hear you absolutely. Very, very well articulated. Naresh, maybe you can add something. I think, of course, you represent a bigger company. You deal with not only the central TB division, presumably you deal with other government health programs as well. So something that perhaps the TB program can learn from other arms of the government, or something else that you've seen that is noteworthy.
Thank you, Karthik. Personally, if you ask me, I think TB program, as Dr. Prapti also said, is one of the award program in India. I think the best program what we saw was recently was 𝐏𝐋𝐀, where they have worked very hard, and I think HIV program, where also they have integrated everything, starting from civil society to diagnostics and the treatment outcomes. They have measured it so well. Now, I think it is one of the successful program. Tuberculosis is exactly moving in the same direction. If you see, only thing is right now we have a lot of newer innovations available, and these innovations should be plugged in at right time, so that these benefits can be passed on to the patients. If you see today, we are still using sputum microscopies, which has maybe somewhere around 50% accuracy, and unavailability of imaging, like X-rays. Minimum X-rays are available in our country, where I think solutions like deep tech, Cure AI can seriously help government to predict these to do precision diagnostic as early as possible. So I think plugging in this on right time is so important. As you know that we are already in 2022. We're left with just 3 years to target at least the goal what we have decided. So no doubt there is a war footing basis work going on, and we will see a lot of new things coming up 2 days from now, where they are having a fantastic program on World TB Day, where they will be unveiling a lot of newer things. So yes, all of us have to. I feel all of us have to come together and make sure we are presenting ourselves very well to the program. The benefits which each organization can offer, it will be fantastic.
Thanks, Naresh. I think some of us in this session, when I think back, we've talked about, especially because we are a diagnostics-heavy panel, there have been a lot of advancements, a lot of capacity built due to the COVID epidemic, right? For the longest time, for a year and a half, we didn't have vaccines, right? We still don't have very effective drugs. So the only approach as a public health intervention we could do was, all right, let's build testing capacity so that people know they're COVID positive, they can isolate, get care, and they don't further transmit it to others in the community. And I think this is another hallmark that at its peak, I think, because we were tracking this quite aggressively, India was doing about 3 million 30 lakh COVID tests every day, right? I think that's where we peaked as a country, both public and private, right? And a large, I think about almost 60 or 70% of those were RT-PCR tests. So we're looking at almost about 20 lakh RT-PCR tests of COVID being done every day, which is incredible. If you told this to me 3 years back, I would have not believed anyone. I said, we've all spent the last 10 years trying to scale up diagnostic capacity for TB, but just in 2 years, we've seen this scale up, right? And so I'd love to get thoughts on, I'd like to think that the COVID-19 pandemic is coming to an end, or it's becoming endemic, and perhaps the role of testing will still be there, but not as paramount as it has been in the last 2 years, right? So what do we do with this testing capacity, right? People are trained, there are instruments, there are reagents, there's know-how, there is, sample referral networks. All of those things are largely in place, right? Theoretically, it's very easy to say, of course, we should be using it for TB. Of course, we should be using it for other infectious diseases. But is that realistic? And, how would you like to see this infrastructure being used in the future? So long question, but I think a lot of you are very well placed to answer this. So I'll probably go to Dr. Amit first, and then I'd love to get thoughts from Dr. Vedam and Dr. Prapti as well.
Yeah, thanks, Karthik. I think, yes, I think there's a lot of capacity which we suddenly realize that there is existing in the ecosystem. There's a lot of elasticity in the ecosystem. COVID actually has shown that elasticity to us, that this is possible. This could be something, a similar mechanism could be even deployed for tuberculosis screening. And the next 3 years could be the real testing phase for us, where we go to the community and ensure that what we did with COVID, what we learned from COVID, we don't let it go waste. We use every bit of that knowledge to build on the TB screening and TB detection ecosystem. Saying that specifically from my field, I would like to say that a lot of technological innovations are happening on a day-to-day basis. As I said, the AI technology is now available even on edge. The sizes of edge devices itself have gone down significantly. Over and above that, these solutions are hybrid, so they could be syncing to cloud as and when required. Moreover, the hardware, which is there in terms of the X-ray machines. So if you have seen, there's a lot of changes there as well. Like the last 2-3 years, we have seen a significant number of backpack X-ray machines coming in. And these technologies make it so easily accessible that you can take this X-ray as a laptop or as a DSLR camera to the very much periphery, get a scan done, screen it with AI, and get the results, and then plan the next course of action. I think it's all about amalgamation of these technologies, and because changes are happening on a day-to-day basis, because like every few months new technology is coming in, I believe there could be a lot of new learning which the government machineries need to go through. And I understand their challenges because they have to look at the entire perspective, the bird's eye view, which Naresh was talking about. And I think everyone in the ecosystem has therefore equally large responsibility to communicate their thoughts well with the government through an ecosystem which Naresh and team are looking at. So we could all plug in with our own thoughts there. And once we have those thoughts in place, once we give them the newest, latest update, validated update, I think we probably will be looking at much more granular levels to connect the dots. So that's a small take from my side, Karthik. Over to you. Thanks.
Thank you. Dr. Vedam?
Yeah. So if you take a look at COVID, it came from nowhere. And just 1 year, we could scale up the testing all through the country in something, as you mentioned, Karthik, we couldn't even imagine. TB is there with us for the last, maybe in the country, programs have been there for the last maybe 50, 75 years. We have protocols, we have SOPs. We have studied this disease much, much beyond than what we have done for COVID. So it is not the lack of technology. It is not the lack of public-private partnership. It's the mission mode that which we execute this. So it's execution is the king. Okay. So COVID was killing people every day. Every day you can see people dying in the hospital. So there's a huge pressure on the public sector, huge pressure on the policy making people, huge pressure on government, health departments. So this made this achievable in just 1 year time. As you can mention, the SMS is going, the ICMR portals coming, the digital infrastructure, hundreds of labs empowered. Just imagine enable accreditations for COVID happened few hundreds of labs within few months. The NABL inspections were happening midnights, 12 o'clock, 1 o'clock they were doing. They worked very hard, very hard. So that kind of a mission, we need to see what makes, what kind of a thing has to happen to bring it to that execution. I think I don't see any challenge in infrastructure, money, funding. The TB has been funded by so many non-profit organizations across the world, including WHO. There are so many philanthropic grants coming up. It's you have to amalgamate everything. You have to bring startups. You have to bring companies like Viatris. You have to bring multinational entities. Everything it's a mission more like how we did in 2 years for COVID. We couldn't do for last maybe 50 years. But at the same time, I'm not trying to be pessimistic here. The kind of a streamlined program that has been done, the implementation, compliance, different non-government organizations working for TB and all has been extremely good, at least in India. And the government, I've been seeing various programs government is rolling out. Their intention is very clear that they have to do something very serious. But the scale at which and the focus at which it needs to happen has to be much more bigger. So I think that's something which is lacking.
Sure. Yeah, no, mission mode. I think we've done it with polio. We did it with COVID testing. We did it with COVID vaccines, right? Yes. I mean, to think that we are now sitting at about 70% overall vaccination for a country of India's size is quite incredible, right?
So just imagine if you have to go in airport, you need to have COVID certificate. You need to have RT-PCR testing. So this kind of adherence has to come for TB positive patients, whether you have taken your tablet. Otherwise, I won't let you get in a flight or let you get into a bus. I won't give you certificate. But these are things that we need to implement very hard.
No, absolutely. I hear you. Dr. Prapti, I think we'll go to you.
Yeah, I couldn't agree more with Dr. Vedam and Dr. Amit, and they've really articulated it well. Just the context of how RT-PCR has become a regular conversation. Like everyone now knows what an RT-PCR is. They ask what strain of COVID you had. As if it's jargon. It's jargon now being used in an everyday conversation. I think that is definitely contributing to the awareness. Something as simplistic as and non-trivial as wearing a mask, the awareness to protect from respiratory infection is really not trivial. I'm not saying it'll solve the whole problem, but it's definitely a step in the right direction. Genomic testing, we started out in 2019 and people were so skeptical about DNA sequencing. Cut to 2021, where people are like, oh, I understand genomic testing, talk to me about sensitivity and specificity. So definitely, mindsets have evolved, and it's really up to us to capitalize on this change in mindset. And I love Dr. Vedam's thought process on, like at the airport, you have to show your COVID passport. Build out these, passports and mechanisms which will really help us as a society deal with public health issues. So I'm super excited about what's to come and optimistic.
No, thanks. Thanks, Dr. Prapti. I knew that this RT-PCR, now everybody talks about it, but even my mother understands. In fact, she would ask, what is the CT value, right? So to think that my mother, somebody who has absolutely no technical know-how, would be asking CT values to relatives who've been diagnosed with COVID, it's incredible, right? So really, I think something that kind of awareness in the general population is going to help us. I'm looking at the time, and we're almost at time, right? But we are having this session because it is World TB Day in 2 days, right? And so maybe a good way to conclude, I was thinking, is just I'll go to each one of you, and for maybe half a minute, if you can just give some closing remarks. Like someone said, we only have a little more than 3 years now to 2025, right? And in all fairness, the government is treating that deadline quite seriously. I don't see any wavering on that deadline. Prime Minister Modi is talking about it. So it is something that we are trying to execute in mission mode. So I'll just go to, maybe I'll go to Naresh first, and just a quick half-minute closing remarks from all of you, and then we can close the session today.
So I think very interesting panel. I think the way Dr. Ram was explaining about the COVID infrastructure, what we developed so fast, and I think huge learning actually. When I was listening to all of you, huge learning this side, because I think TV program, I will say that maybe a fortunate program, all infrastructure built. Now I think they can capitalize this. They know how innovations can be utilized the way we utilized in COVID. Like you pick up COVID app, I think it changed the whole picture actually for vaccination as well as for ICMR. So similarly, I think it's a very good thought process. COVID has taught us, which surely should help us in elimination of tuberculosis by 2025. Thank you.
Thank you, Naresh. Dr. Amit, we'll go to you quickly for some closing remarks.
Yeah, I think just to summarize, we have the potential to use and pivot or kind of work simultaneously on both these two pandemics, use the same scale what we have built for COVID, and kind of use few of these infrastructures for TB screening, and ensure that we don't lose or leave our guard down even for a moment, and we go ahead, build on top of this, and ensure that we eliminate TB by 2025.
Thanks. Dr. Vedam?
Yeah. So this World TB Day, I think we all should pledge whatever support we can give from our organizations in best what we can do. So from perspective of 𝐓𝐁'𝐻, I think we are very keen to work in a very non-profit way with like-minded organizations, collaborators, partners, government especially. Very happy to see the kind of intention and the kind of preparation government is doing. And Karthik, very glad to hear that government is taking very seriously and then don't want to miss the deadlines of 2025. So hopefully we see that things progress very fast and we execute things in a proper way, in a collaborative way.
Sure. Dr. Prapti?
Yeah, we're super excited to come together in this multidisciplinary approach towards really, stop playing this game of catch up with these pathogens and start preemptively using technology to overcome and win.
Thanks. Thank you. Thanks all four of you. I think we are in the middle of the week. You've given us 1 hour of your time. So thank you very much. Thank you to 𝐕𝐻 for bringing focus on this important disease. And thank you for Viatris for supporting this panel discussion. Of course, I think we will. This will be shared through the 𝐕𝐻 page and LinkedIn pages. So I would encourage you to share so that we can get the word out there. Have a safe rest of the week, and I'm sure I'll be seeing you all very soon in physical events. So please take care of your health and keep up the good fight. So thank you.
Thank you.
Thank you, Karthik. Thanks for having us.
Thank you, everybody. Thank you.
A very good afternoon to everyone. Taking the discussion forward, while all our panelists have very well set the context of this panel discussion with the topic, use of digital technology to enhance tuberculosis control. During the discussion, all the speakers have very extensively deliberated on the aspects like digital technology and the extent to which the industry shall adhere to these models of screening and diagnosis of tuberculosis, and how in turn it is helping to combat the disease burden in India. Our experts also very insightfully had put up their take on the interdependency of COVID-19 and tuberculosis, both on the clinical aspects such as prognosis and treatment, and also a little bit on the public health aspect. For example, the clinical research to combat COVID-19 pandemic came at a very heavy cost to TB in high burden countries like India, as TB related advancements were reprioritized. Now, taking this engaging discussion forward, I have with me Mr. Dara Kelleher. He is the Director of Public Health Outreach at 𝐄𝐍𝐃.AI. In a brief, 𝐄𝐍𝐃.AI uses deep learning and artificial intelligence to bring access to quality healthcare, especially in the remote areas. A few years back, 𝐄𝐍𝐃.AI had been in limelight for developing a software to provide fast and accurate diagnosis of tuberculosis. I'm sure during our course of this conversation, Dara would extensively talk and let us know a little more about it.
So let us take this discussion forward. Welcome, Dara, first of all. Welcome
Thank you
to the
very much
panel.
for having me. Great to be here today.
Thank you. So taking this discussion forward, with the expansion of health tech research, there is now wide availability of digitally enabled solutions for TB diagnosis. And we here have been very lucky to have the top most solution providers in India in this panel. We have deeptech.ai, we had Arogya AI, and now you with us representing 𝐄𝐗𝐏𝐄𝐑𝐄. Now, in a country like us, and keeping in mind the enormous population that we have in the country, and also the aspect that the major chunk of this population represents the rural portion of India, where we have challenges like accessibility, availability, and awareness amongst all. Now, how do you think this helps in combating the disease burden of tuberculosis? Over to you.
Thank you very much. So I think what you said is right. With India being the highest TB burden country globally, there's an opportunity for technology to be used both in the urban and rural settings. 𝐄AI has been on the front lines of TB screening using their 𝐄𝐋 solution for more than 5 years now. And not just from a digital point of view, but also in collaboration with the India Health Fund, we developed a tool for those rural settings where you can use analog X-ray films and capture pictures of these from a smartphone and get that AI interpretation. At 𝐄AI, we believe that TB screening is a fundamental part of improving general overall outcomes in healthcare. And that's why at 𝐄AI, we don't just focus on TB screening as a lung pathology. So 𝐄AI actually on our chest X-ray product has 30 CE approved findings. So what we're trying to do is look at the fallback that's happened over the last 2 years in the TB screening, bring back the TB screening, which is highly important, but also look at other lung pathologies and try to bridge the infectious disease and non-communicable disease focuses. So when a patient goes for screening and this tool is being used, if it's not TB, we can help suggest what the other abnormality is causing that respiratory distress.
Okay, so what you're talking here is it not just it is helping in at least examining and screening TB, but also if there is any other comorbidity or any other lung related disease involved.
Exactly. So one of the things that is important to understand is that we still don't have enough data on the likes of long COVID, for example, and the impact on the the health systems going forward. There was a huge amount of chest X-rays were taken over the last 2 years, a lot more than in the past. The trend is going to continue because of the lack of available human readers. So AI is going to continue to become an important part of this. But beyond the AI algorithms themselves, we've also helped build digital tools such as our product 𝐄Track, which actually helps enable multiple centers to centralize that data so that where you have human readers available, we can help centralize this data while giving the AI interpretation for that particular examination.
Okay, so while maintaining and enhancing the extent of diagnosis and screening of chest X-rays and everything, we're also managing data at a very efficient extent. Great. Moving on, Dara, now the COVID-19 pandemic, as we just briefly mentioned, the pandemic had briefly displaced tuberculosis as the world's leading infectious killer disease. TB services, while I talk about the country, has immensely affected during the pandemic, which had briefly struggled to regain normalcy. Now, what do you think? Simply resuming services as usual is enough, or any further interventions are required or need to be planned, or in case are there already in place and we just need to address those? Also, along with that, if maybe you can elaborate the role 𝐄AI is playing to address the disease burden, again, as you briefly mentioned in the first question, and also how well it has been globally accredited. Over to you.
Thank you for that question. It's a very interesting one. And I think without getting into deep, we all know that when the political will is there, funding and support can be really driven towards particular disease burden. So one of the hopes and aspirations I have personally, but as well as Cure, is that more focus now turns to TB, and we don't just think about what the status quo has been for the last decade. We really try to break the mold with this. One of such things is that, although in certain circumstances you may have access to, molecular diagnostic systems as well as expert human readers, the ability of AI support in general, I believe that AI needs to become more widely adopted, which will in turn help, access for these patients. COVID has really disrupted a lot of healthcare settings. So in terms of, trying to get back on track, it cannot be just going back to the way it was. We have to go a step further. So now with this week, World TB Day, I think there's a lot of pressure now being put on to increase the funding that had been committed towards TB screening globally.
Yes, correct. And I think before this also, our panelists have very much and very well stressed upon the fact that COVID-19 has taught all of us the capacity at which our screening and diagnostics can scale up to. As in, it was just a matter of time that we're able to do millions and millions of tests in a single day. So maybe I think if we take up the TB, burden in that aspect, we'll be able to combat the burden and maybe achieve the goal that we are trying to look at. That is to eradicate TB by 2025 in a very efficient way. So thank you, Dera. Those were it. Those were my questions. But before parting, would you be interested in probably giving a one-liner message or a brief short recall on the World TB Day today to all the viewers?
I would. I think it's something very close to my heart. My mother was a public health nurse in Ireland for TB back in the 60s, 70s when the pandemic of TB was still in play. So I know very much how it has impacted lives all over the world. What I would say is that when looking at TB eradication, we need partnership and we need to look beyond our silos. We need to really garner the expertise from all facets of the healthcare system, because by improving TB care, TB screening, this is going to, in fact, improve the entire ecosystem for healthcare and improve the outcomes of patients who most need it.
Absolutely. And also adding to the fact that since India is at a very high burden of TB, if we reduce our numbers, I think it will help the global eradication of TB as well. We'll be able to play a major part in that. So I think thank you so much. By this, we conclude this session and also the event. Thank you for being here and sharing your views. Thank you so much.
Thank you much, Kashibu. Pleasure. Thank you.
Thank you.